Yes, Dr. Abajin, can I start? Dr. Abajin, unmute yourself and start, please.
Hello, doctor. Can you hear me?
Yeah, please start.
Yeah. Good morning, Mr. Suwan.
Yeah,
I'm your doctor. I'm your doctor here in medical outpatient clinic.
yes,
So
Doctor.
may I confirm you are Mr. Suwan, 45 years old?
Yes, Doctor, I'm Susan.
Okay. Mr. Susan, today we are going to talk about your health condition.
Yeah.
So I ask for your permission that we proceed from we continue to discuss about your health condition. Is it fine?
Yes, Doctor, please.
Okay, so Mr. Susan, can you, I have received a referral letter from your GP
Yeah.
telling me that you have been having this loose motion. Do you mind
Yeah.
telling me more about the loose motion?
Yes, really, Doctor, I'm suffering loose motion since around 3 months. Increase more over the last month. I saw many doctors for this, but I didn't find any benefit, really, Doctor.
Okay, so this loose motion, does it start suddenly or it comes like
Yeah,
gradually?
yeah, it started about 3 months before suddenly, but really it increased, Doctor.
So it has been worsening for how long?
3 months, it started 3 months.
Okay, since how long is it worsening or remain the same?
Increase.
Increase, okay.
Yeah.
So can I know in one day how many times you have the loose motion?
Yeah, doctor, actually, I open my bowel about 6 to 7 times daily.
6 to 7 times.
Yeah,
Do you mind telling me how is the motion look like?
it's like water, doctor, watery.
Watery. What
Yeah,
is the color of the motion?
actually, doctor, it looks pale.
Pale color.
Yeah, yeah.
Do the motion have any blood?
No, I didn't notice any blood.
Okay. Is it foul smelling?
Really, doctor, yes.
Foul smelling.
Yeah,
Do the motion has any slime or any mucus in
yeah,
the
yes, doctor. I noticed slime, yes.
how is this motion different compared to your previous motion?
Really, doctor, before over the last year, really, I have a hard motion. I open my bowel only 3 to 2 times per week. Also, I need to strain to open my bowel.
Okay. So
Yeah,
now you are having loose motion and
yeah,
increase in the motion.
yeah.
Do you feel that you lost a lot of weight?
No, doctor, my weight increase. I noticed that my weight increase.
For how much does the weight increase?
Really, doctor, I gain weight over the last 5 to 6 years, about 10 kilo.
Okay. How is your appetite?
Really, doctor, I feel like that I'm eating more because I feel that food sometimes improve my tummy pain. So I'm eating more, doctor.
Okay, so you are having tummy pain as well.
Yeah, yeah, yeah. I have burning pain in my tummy.
Burning pain.
Yeah.
Can I know exactly where is the pain?
Upper part, doctor, of my tummy.
Okay, do you feel nauseous?
Yeah, it is really, doctor. I
Do you
feeling
throw
sick with this pain, yes.
okay, do you throw up?
No.
How is does the pain go any other part of your body? I mean your tummy?
No, doctor, only in my, I mean, the upper part of tummy.
Do you have any acid taste in your mouth?
No.
Do you do you have like you feel full even though you have eaten just a little bit?
No, doctor.
Does the food that you have swallowed come back up again?
No, doctor.
Do you have any difficulty in swallowing? Do you have any pain?
No, doctor.
Okay, did any of your family or friends that tell you that your eye is getting a bit yellow?
No.
Okay, so Other than tummy pain and also your change in your loose motion, what else that do you have?
Like what, doctor?
Okay, so do you have any joint pain?
Yes, doctor, I have pain in my knees, yes.
Okay, both knee or one knee?
Really, right knee more than left knee, but both knees.
Both knee.
Yeah.
Is there
But the
any yeah,
right more, right one more.
okay, right, one more. Is there any early mornings you feel your knee is stiff,
No, doctor, no.
only pain,
Yes, I noticed one time also it becomes swelling.
swelling?
Yeah.
Do you have any increase in body temperature?
No, doctor.
Okay, swelling. When was the knee swelling?
About 1 month before, I saw my GP. He told me maybe this is due to osteoarthritis or like this. He gave me some anti medication. He told me anti-inflammatory and also give me gel. I'm feeling better now.
Okay, so do you feel pain with the joint, the swelling?
Yeah, yeah.
Is it warm on touch?
No,
Okay, so any back pain?
no back pain, doctor.
Okay, so um for sorry for asking you again for the loose motion, do you notice it as any association with any food intake, any particular like rice or any oats?
No, doctor.
Okay, so I'm going to run through a series of question for you just to make sure that everything is, I mean, I didn't miss out anything for you.
Yeah, yeah, doctor.
Okay, is that right?
Yes, doctor.
Okay, do you have any headache?
Yeah, really, doctor. I'm suffering headache since long time.
Okay, how is the headache? Where is the headache exactly?
Really, doctor, affected the front area and behind my eyes.
How is the pain like? Is it like a tightening band like sensation, or it's
It
like
looks
throbbing,
it's looked like dull egg, doctor.
dull ache
Yeah.
behind the eye?
Yes, and the front area also.
Do you have any redness of your eye or tearing of your eye?
No redness in the eyes, no.
Okay, is it the headache is becoming worse?
Really, doctor, I cannot recognize anything can worse it usually.
Okay, how does the headache usually how do you recover from the headache?
Yes, sometimes I'm taking paracetamol. Really, it's mild, doctor. It's mild headache, not severe headache. So, but improve with paracetamol. But I try to don't take more because I know that this can affect the kidney, the paracetamol.
Do you have any loss of consciousness?
No loss of consciousness.
Any neck pain or stiffness?
No, doctor.
Any weakness of your limb?
No weakness.
Any loss of sensation that you are unable to feel pain or cold?
No, doctor.
Any facial weakness?
No, doctor.
Do you have any difficulty in speech or speaking to
No, it's okay.
understand?
My speech, okay.
Do you have any problem with your walking?
No, it's okay.
Okay. How is your memory? Do you have
Really,
difficulty in?
doctor, I'm feeling restless and difficult to concentrate in my job and daily activities, really.
Okay. How long it has been like that? I mean, yeah.
Since a few months, doctor, I cannot remember well, but it increased gradually, so I cannot recognize when did it start exactly.
Okay. Do you have any like you see the surrounding is spinning? You feel
No,
dizzy?
no, doctor,
Okay. Any shakiness?
no, doctor.
Any can you control your urine and also your motion?
No, doctor, but really I am passing urine more than before. Really, sometimes I need to go bathroom about 10 to 20 times sometimes per day.
Okay. Do you wake up at night to pass urine?
Yeah, many times, 4 to 5 times per night.
Okay. Any blood in your urine?
No,
Do you feel that you after you pass out urine, you still have the sensation to pass urine?
no,
Do you are you able to reach the washroom? when you want
Yeah,
to
yeah,
use
no
it?
problem. Yes, doctor, but really I'm going frequently to bathroom.
Okay. So do you have any like you unable to tolerate heat or cold weather, hot and cold weather?
No, no, doctor.
In any how about your menses? Any problem?
No, doctor.
Okay. So do you have any
No cough.
coughing out of blood?
No,
Any noisy breathing sound?
no, doctor.
Any shortness of breath?
Yeah, yes, I have shortness of breath when I am walking or climbing stairs.
Okay. So is it worsening? For how long it has been having this short
Since 1 year.
1 year?
Yeah.
Okay. Any do you feel of heart racing fast? Any chest pain?
Sometimes, but not always, doctor.
Where exactly is the chest pain or the
No chest pain.
no chest pain?
No.
Okay. Do you feel that you can feel your heart is beating?
Yes, I told you so, doctor. When I'm walking fast sometimes with shortness of
Oh,
breath.
do you have any swelling of your leg?
Yes, I have mild swelling in my legs. Maybe because the medication my GP told me that this may be due to amlodipine that I'm taking.
Okay. So the amlodipine, is it newly added? I mean, newly prescribed by
No,
your
I took about now since 4 or 5 months or more.
oh, okay. So the swelling, can you when do you try to press the swelling, is it then become
Yeah. Yes, doctor.
okay? Um, do you have any previous other
To,
than
2 minutes. Yes, doctor.
true okay? Do you have any do you other than the the high sugar level and also hypertension, what else
Yeah.
that you have previously?
Only hypertension and diabetes.
How is the control like?
Really, doctor, it's difficult to control it.
Okay, the diabetes, may I know you are taking your medication orally or by injection?
No, orally only.
Orally only.
Yeah.
Do you remember your HbA1c in the last clinic visit?
I remember that last one, it was 8.
8.
Yeah.
How about your hypertension, your high blood pressure?
Uh, Really, doctor, not controlled. Always when I check it, 160, 150, 170, like this.
Okay, do you feel what medication you are on other than the amlodipine?
I'm taking also Brendopril, 10 milligram.
Only Brindopil and amlodipine.
Yeah.
Okay. Do you feel you are feeling like hot rashes or anything like that?
No, doctor.
So what is your concern? May I know?
Doctor, really, I also always when I see my face compared to the old photo, I see my face it's look bigger than before. Also, I need always to change my shoes because the size of shoes become uh, small. So really, I have also concern about this. So what can be this, doctor?
You mean your shoe size becomes smaller
Yeah, yeah, I need to change always.
and also your appearance is
Yeah,
different.
when I saw old photo, I feel the appearance is different, doctor. Really.
Mm.
Okay, Doctor, time off. Thank you very much, Dr. Abajil. But I will give you some time uh, to take you, yani, to discuss with you what the cause. So now, according to your history, what did you
Yeah.
find? Findings. What your findings?
I find this patient with history of diabetes mellitus and hypertension not well controlled
Very
and
nice.
has a chronic diarrhea. Mm,
Diarrhea, chronic
there is
diarrhea.
also increase in weight
Yeah,
and also tummy pain
yeah.
with
What tummy pain? What
polyuria
this
and
tummy pain? What this tummy pain? This tummy pain characterized for what? She has
burning
burning
uh,
sensation.
Yeah,
in
burning
upper
sensation.
part of tummy. So this is peptic ulcer disease.
Most likely gastroesophageal reflux.
Why not peptic ulcer disease? She has no acid taste in her mouth, no acid taste. She told you only I have burning sensation, heartburn. And if you ask her, he will tell you that this increase when I'm become hungry or when take spicy food and improve
Oh,
when I eating and drink. So this pain most likely peptic ulcer disease. Okay,
okay.
so and she has signs. This patient she has uncontrolled diabetes, uncontrolled hypertension. She has also chronic diarrhea. She
Yes.
has stomach pain, peptic ulcer disease, and she has symptoms of hypercalcemia. Why this patient open? She has polyuria. If you ask me about the other symptoms of hypercalcemia, I will tell you if I feel thirsty most of the time. Also, she told you also she feel restless and difficulty to concentrate, and she
Mm.
has also the tummy pain can be due to hypercalcemia. I know this case is difficult; it's not easy and need time, and most of candidates will not finish within the time. But this is really it came before in basis exam many times. So when we know this case, we can now in the future you can manage this case very well. I'm sure because now you will know what the diagnosis. So when they mention for you outside, they helping you. Really, they are helping you now. They mention for you outside. This patient has uncontrolled. You see, it's certain. She has diabetes and hypertension. Both are not controlled well despite treatment. So, when you prepare your case, you should read this is very well. They not mention it only for mentioning. They mention it to use it outside. Do you use it outside, Doctora Abhijil?
Yeah, yeah.
So, what the differential diagnosis of patient have uncontrolled diabetic and hypertension
Mm,
usually? We have Cushing disease,
yes.
we have acromegaly.
Yes.
Yeah, this both disease can cause uncontrolled both uncontrolled diabetic and uncontrolled hypertension. Both disease can cause this is symptoms. There are other disease, but usually these two disease can cause both. Okay, so
Okay.
outside you should know, you should put in your mind this patient has symptoms of uncontrolled hypertension and diabetes. So maybe she has acromegaly or maybe has Cushing. For me, how can analyze these symptoms? This patient has uncontrolled hypertension and diabetes, so maybe acromegaly and maybe Cushing. Okay, I put in on the side. And this patient has chronic diarrhea. What the cause that can cause acromegaly or Cushing with chronic diarrhea? What the disease can cause this one? If you have no idea, no problem, because they are here to learn.
I'm
So,
not sure the
yeah, uh, we have disease called MIN1. MIN1. Multiple neoplasm MIN1. Okay? Yeah. So, we have disease called MIN1. What this mean one? MIN1? Multiple endocrine neoplasia 1. What the component of this disease?
pituitary.
Yes, hyperparathyroidism.
Okay.
Okay? The other,
Pituitary involvement.
pituitary adenoma, either growth hormone or ACTH or prolactinoma. Okay? And the third one, what this can be?
Um,
The common one. There are many tumors, but the common,
pancreas involvement.
yeah, Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. This is usually gastrinoma. Gastrinoma. Okay, but we can see other types like insulinoma, VIPoma, glucagonoma, carcinoid tumors. All this can be seen, but really the most common one it is gastrinoma that cause disease called Zollinger-Ellison disease. طيب Zollinger-Ellison disease. What are the symptoms of Zollinger-Ellison disease or syndrome?
Peptic ulcer. Multiple peptic
Yeah,
ulcer.
very nice. So the most common cause is peptic ulcer disease usually difficult to control. Yeah, the patient maybe take PPI but relapsed or sometimes not improved with BBI. So refractory peptic ulcer disease. Refractory peptic ulcer disease. This is the first one. Not the patient will not improve usually with BBI, or if he improvement will be low. Two, so refractory peptic ulcer disease. Second one,
Um, Insulinoma.
no, I mean Zollinger-Ellison component.
Oh, I'm not sure, doctor.
Diarrhea will cause
Oh,
diarrhea and abdominal pain. This is the two component of the disease. Okay, so
okay.
so we are here. The patient has manifestations of acromegaly. He told you later on. He have change of the facial features, increase the size of shoes. He has uncontrolled hypertension, uncontrolled diabetes. Okay, and he told you also I feeling shortness of breath when I'm walking, and also I have edema in both lower limbs. For this patient can be has cardiomyopathy due to also acromegaly. He told you that I have knee with swollen knee. So this patient who also maybe has pseudogout. This is as also manifestations of acromegaly. So really this scenario is not easy, but it came many times. And in the future, I am sure 100% that you will do it 100%. When you see outside patient has uncontrolled hypertension and diabetes, and he has chronic diarrhea, so the diagnosis will be very easy for you. So this
Oh,
patient has main one, she has acromegaly manifestation, she has Zollinger-Ellison syndrome, she has manifestations of hyperparathyroidism as polyuria and polydipsia, and also confusion, as she told you, difficulty to concentrate and restless, and she has also, as we know before, hypercalcemia can cause peptic ulcer disease also. Okay, so what investigation you will do for her? Now you are know the diagnosis. So what you will do for her?
I will do ser
Yeah,
cortisol level, growth
yeah.
hormone,
Grow.
IGF,
We will do growth hormone only.
insulin-like
Yeah,
growth factor.
very nice. One, insulin like growth factors one, or you can
Mm,
for diagnosis growth hormone suppression test. Okay.
okay.
What else we will do?
OGTT,
Okay.
oral glucose
Yeah,
tolerance test. Yeah.
yeah. This is what's called also a growth hormone suppression test. Same one. Yes, you are
Oh,
right.
okay. Okay.
What else? What else?
And also thyroid, all the thyroid
B
function tests.
Yeah, BTH, you will do BTH also. Calcium and BTH, corrected calcium and BTH, because this disease can cause hyperparathyroidism. طيب, for gastrinoma, what you will do for gastrinoma?
Gastrin.
Yes, because this patient, we told that she has Zollinger-Ellison. Zollinger-Ellison caused usually by gastrinoma. So what you will do for her? Fast, fast,
OGDS.
fasting serum, fasting gastrin level.
Okay.
Okay. Also, this patient need to do abdominal CT, because how can diagnose gastrinoma? We need CT abdomen with contrast. We need to do also neck ultrasound to see parathyroids. We need to do pituitary MRI. Okay, because she has manifestations of acromegaly. How can treat the patient with acromegaly?
Acromegaly, the first line treatment usually is by surgical
Yeah. What's the surgery? What's called? Usually the
transsphenoidal. Uh,
hypophysiectomy.
yeah.
Yes, nice. Okay. Uh, do you have any idea about the medication can be used sometimes as adjunctive therapy, or if the surgery is contraindicated?
The ketoconazole
No.
or bromocriptine.
Yeah, bromocriptine, you are right. Dopamine agonists like gabergoline or
Yeah.
bromocriptine. And what else?
Um, I'm not
Somatostatin analogs,
okay.
octreotide. Also, what else? Growth hormone antagonist, bigvizomant. Really, this medication, you should review it. Why? Because acromegaly in station 5, very common in exam, in PACES exam. Acromegaly, very common in PACES exam as station 5, especially in some centers. So it's very easy to diagnose it when you see the patient has cross features of his face, and he has also all manifestations like uncontrolled diabetes, uncontrolled DM, headache. And really, this patient, you ask me about if I have gritty eyes or redness, ma? Yes, but
Yes.
you don't ask me about vision. You see, very, very important. When the patient has headache, you should ask about uh, acuity, vision acuity, not only redness of the eyes. Because if you tell me you have a redness, no, I have no redness of eyes. I have no, but I have blurred vision. You don't ask me about blurred vision. You ask me about gritty eyes and redness eyes. So you should ask about blurred vision when you, any patient have headache. Second question after analysis of headache should be blurred vision. Clearly, blurred vision or loss of vision. Here the patient will answer you. Other than will not answer you. Be sure. Redness of the eyes? No, I have no redness of the eyes. I have no gritty eyes, but I have blurred vision. So, the next question. For Zollinger Ellison, how can manage it?
Proton pump inhibitor,
Yeah, but usually the patient usually not improve well. What else? Also somatostatin analogs like octreotide. Okay? So
okay.
this octreotide can be help in acromegaly and can be help in gastrinoma and also surgery. Also surgery can be considered because also it's tumor, so can be considered. So last question, as I mentioned for you before, what tumors can be seen in patient with min 1?
What tumor can be seen?
Yeah, in pain,
Um,
we mentioned it before. We can see,
parathyroid adenoma,
yeah,
and then pituitary adenoma,
yeah,
gastrinoma, insulinoma,
very nice. Vipoma,
mm,
vipoma, VIPO, okay, and glucagonoma, glucagonoma. So, before, and this is mentioned in all PACES books, it's mentioned. For any patients have manifestations of Cushing disease or patient have manifestations of acromegaly, you should ask some questions to rule out min 1. This question usually, do you have any change in your bowel habit, like chronic loose motion? Do you feel thirsty? Do you pass urine more than before? And do you have a burning sensation in your tummy? This is 4 questions should be asked for any patient, especially in station 5. In station 5, if you have case of Cushing or you have case of acromegaly, you should ask about this 4 questions to rule out that this patient has no min 1. Okay, and exam wise, any patient with a chronic diarrhea, you should also, especially this patient, if you see she has watery diarrhea, not offensive. And why, I will mention now, I will mention what the cause of this is. Mixed picture of diarrhea, mixed picture. Really, this patient has mixed picture. She has secretory and also she has malabsorption picture of loose motion. Thank you, Dr. Abajil. You are doing
okay, thank you.
today. You are doing very systemic review. Actually, I'm not. Uh, I'm telling you that true today that you did full systemic review and really the analysis of GI system here today very nice. You complete. You ask me all the questions related to GI symptoms. Really, you don't forget any questions. But really, the time limited in this case. So how can manage our time by know the differential diagnosis from outside? From outside, you should think about diagnosis for this case that this patient why have uncontrolled diabetes and hypertension. So you should put in your mind your differential diagnosis that acromegaly and Cushing both can cause uncontrolled. So inside you should ask about these 2 diagnoses, especially that the patient tell you that I have gained weight, I gain weight. So this is diagnosis 2. If you ask me direct, if you put in your mind that uncontrolled diabetes and hypertension can cause together by these 2 disease, so inside you can target your questions and you will reach the diagnosis. And always to reach the diagnosis, you should put this diagnosis in your mind. Now you put that main one. It came before in basis exam, so I should put in my mind, in the exam. Really, when the one put any diagnosis in his mind, he will not forget it. We have many disease, really many disease. It's difficult sometimes to think if you don't put in your mind before, or you don't, or nobody inform you that this appear in exam. Really, like Sheehan syndrome. Sheehan syndrome, it appeared many times in exam before, and nobody think about it because if you don't put in your mind, you will feel that this is other diagnosis. Thank you, Dr. Abajil.
Okay,
So,
thank you.
a discussion for diarrhea. First of all, how can any patient for diarrhea, you should ask
Dr.
the
Hassan,
patient.
can I ask you just one question before you proceed,
Yeah,
please?
please.
Confused me. The Zollinger-Ellison, you said it's not only with peptic ulcer disease, it's come with chronic diarrhea. Is it that?
Both,
Why?
refractory, it cause refractory peptic ulcer disease and chronic diarrhea. Gastrin, the gastrinoma, gastrin,
Because what I thought,
yes.
oh yeah, the gastrin, because of the gastrin.
Yeah, gastrin substance cause water emotion, cause secretions.
Why there is a malabsorption feature?
So this is the two component of the
Zollinger-Ellison.
yeah. You should know it
And
that what the manifestation of Zollinger-Ellison, these two, refractory peptic ulcer disease and
Chronic
secretory
diarrhea. And why you said in the investigation, why did you said, so you said fasting gastrin level to rule out Zollinger-Ellison, yeah? Fasting gastrin level,
Yeah.
that's enough? That's enough.
And secretin. The other substance, it's called secretin also. I'm not sure how this is secretin. Also, it's mentioned that also we can be high, this substance also in the Zollinger-Ellison. But the diagnosis should be also by abdominal CT.
Sure. And the ultrasound thyroid, so you will discuss that about it, huh? You will tell us
Parathyroid,
about
yes, we should do parathyroid.
parathyroid or ultrasound or thyroid?
Neck ultrasound. Tell the examiner neck ultrasound. I will do neck ultrasound.
Neck ultrasound. Okay, sure.
Yeah.
Thank you.
So, any patient with chronic diarrhea or chronic diarrhea, we are now talking about chronic diarrhea because acute diarrhea is different. Onset, course, duration, and previous attack. Finish. This is all symptoms in exam. You should ask about this onset, course, duration, previous attack. The most important questions, previous bowel habits. And thank you, Dr. Abajid, because you asked me this question. Because this patient before has constipation, she has not normal motion. So very important question, previous bowel habit. How is different from your usual bowel habit? You should ask the patient these questions. How is this different, these symptoms, from your usual bowel habit? This is the most important question when approach patient with any symptoms. If the patient tell you, I have shortness of breath, how is this different from your usual breathing? Why? Because maybe this patient, he has shortness of breath since long time, but now increased. Now he start to seek medical advice. The patient has headache. Maybe the patient has headache since long time. So you should ask this question. How is this different from your usual headache? How is this different from your usual bowel habits? So this is the important question. Then, provoking factors, especially the food here. Does it increase with specific food? Don't ask about rice. Dr. Abajir asked me about rice. Not rice. You should ask about pasta, pizza, beer, milk. Why milk? Milk because also, as we mentioned, lactose intolerance. And does it improve with fasting? Does the symptoms improve with fasting? What's the benefit if the patient symptoms improve or not improve with fasting? As we know that if the patient has secretory process, so will not improve with fasting, like this patient in Zollinger-Ellison. So if the patient has secretory process, usually not improve with fasting, while if the patient has osmotic process, like in patient with diabetes mellitus, usually improve when the patient fast, or like patient with also inflammatory bowel disease, usually the patient if fast also he will improve, but patient with secretory process will not improve, the symptoms will not improve with fasting. Even he fast, he has diarrhea. Then ask about night symptoms. Do you awake at night because would you open your bowel? Would you or do you awake at night to open your bowel? This is very important because also this is give alarm symptoms that for organic cause. Then ask about back passage. Color, it's pale or black. Consistency, it's loose or watery. Amount, is it offensive? Difficulty to flush? Is there any blood? Mucus? Fatty or greasy? Urgency, urgency or loss of control. Here, when you ask this question, you should tell the patient, I'm sorry, I want to ask you if you lost control of your back passage. And then tenesmus. Tenesmus, we know that when you have finished to pass stool, you have feeling that you want to pass more stool. Then go to associations. Full GI history. Full GI history. Like now, Dr. Abajid asked me all the questions. Difficulty of swallowing, acid test, do you feel full just eating? Does the food come back up in your chest when you just eating? Ask about burning sensation or heartburn. Ask about tummy pain. Ask about yellowish discoloration. Ask about also what we call difficulty of swallowing. We mentioned it. Okay. Then, as I mentioned for you, large volume of watery stool unaffected by fasting. So this suggests secretory process like gastrinoma, like vipoma, like carcinoid, also carcinoid common in exam, and diabetic autonomic neuropathy also can cause this picture. So secretory process usually cause large volume of watery stool unaffected by fasting. And malabsorption, as we know, malabsorption cause steatorrhea, that passage of pale greasy stools, and difficulty to flush. In Zollinger-Ellison disease, usually cause mixed picture, of secretory and malabsorption. So this patient has watery stool, has pale stool, offensive, and difficulty to flush. So in Zollinger-Ellison, you can see both together. Symptoms of acromegaly, as we mentioned before: headache, bitemporal hemianopia, uncontrolled diabetes and uncontrolled hypertension, pseudo-gout, cardiomyopathy, sleep apnea, can cause also colon polyps and goiter. Difficulty to control diabetes, always to put in your mind: acromegaly, Cushing disease, hematochromatosis, chronic pancreatitis and cystic fibrosis, medication like steroid, cyclosporine, tacrolimus, and it may be the patient not compliant to diet and medication. Difficulty to control hypertension, but
Again, doctor, what's the differential diagnosis of uncontrolled diabetes again?
Or it's better difficulty to control diabetes, because here the patient will mention for you, I'm taking medication, but even that my blood sugar not controlled well. So we mention better difficulty to control. Acromegaly, Cushing, hematochromatosis, chronic pancreatitis and cystic fibrosis. Also polycystic ovarian syndrome. This is important, I forget it. Medication, steroid, cyclosporine, tacrolimus. And if the patient also not compliant to diet and medication. Difficulty to control hypertension, always put these differentials, and all of them come before an exam. Acromegaly, Cushing disease, Cohn syndrome or Cohn disease, and pheochromocytoma. So hematochromatosis, difficulty to control diabetes; pheochromocytoma, difficulty to control hypertension. Last of all, for syndrome MEN1, usually inherited as autosomal dominant disorder, and can occur also sporadic without family history, and usually characterized by combination of parathyroid tumors, pancreatic islet cells tumors, and anterior pituitary tumors. And exam-wise, most likely will be associated with Zollinger-Ellison rather than other tumors. And for anterior pituitary tumor can be prolactinoma, so sometimes in exam can be prolactinoma. can be also acromegaly due to growth hormone producing tumors, and can also be cause ACTH producing tumors, can cause manifestations like Cushing. This is for all for this case. Any question, please?
Yes, doctor. The difficult to control hypertension, Crohn, FIO, Cushing, acromegaly, and
Yeah,
thyroid, and PCOS.
you are right. لا,
Okay.
BCO,
PCOS in diabetes. Sorry.
yeah,
Okay.
BCO diabetes. Any question, please?
I
diabetes, uncontrolled diabetes causes.
Yeah, together you mean together usually acromegaly and Cushing, and also yes, yes, acromegaly and Cushing together can cause both uncontrolled diabetes and hypertension.
Separately, I mean.
Separately, diabetes mellitus, acromegaly, Cushing, polycystic ovarian syndrome, hematochromatosis, chronic pancreatitis and cystic fibrosis, medication, steroids, cyclosporine, tacrolimus. For hypertension, acromegaly, Cushing, Cone disease, and pheochromocytoma. Or in the future, we have cases, specific cases for each one, because this is very important topic. Ready?
Yes, Dr. Usama, Dr. Hassan, I
Hassan.
have to add something. Yeah,
Yeah.
Dr. Mohammed. Actually, that was my case in the exam. I just would like to tell you something, and everyone will get benefit because I
Sure.
got really, I felt bad because of this. My case was acromegaly,
Yeah.
and it was patient with early morning headache. It was obstructive sleep apnea. But the point is that I forgot it, and now doctor also forgot. I forgot to examine the visual field, and they
Yeah.
wrote in my feedback that I am not safe because I didn't examine the field. Patient did not tell me. He said I have no problem in my vision.
Yeah.
I have no problem inside vision, but I didn't. That's why I didn't examine. However, any case of acromegaly, you have
Yeah.
to examine the visual field because
Yeah.
it was in UK in the Edinburgh, and that was really difficult to. Just my feedback is really made me
Not in
happy at all.
not in UK also or only.
Yes. So
All
any
centers,
acromegaly.
all centers, and the practice in the practical also in real life. Really,
Yes, and Cushing
any doctor,
also.
you should not always, doctor, any patient with headache, go to the vision. Really, any headache,
Yes,
go to the
yes.
vision.
Yes,
Not
yes,
accepted
yes.
for any doctors in our real life also to don't do fundoscopy or visual examination for patient in headache. Really, in a clinic at least you should do. Because how can rule out serious cause of headache like papilledema, intracranial hypertension, acromegaly? How can rule it without vision
Yes,
examination?
and also important point, don't be like forgotten by the patient. He will tell you I don't have vision problem. He will tell you I don't have any
Yeah,
side pumping of the side of the road. I don't have
yeah,
problem in my vision. Again, go
yeah,
because that's what happened with me, and I failed because of this. Actually,
yeah.
very
And
important point.
we have case of acromegaly inshallah in this course. Because they very important and very common to face acromegaly in exam. Very common, like thyroid disease, like rheumatoid arthritis. This is the commonest case in exam. So also acromegaly common
Yes, yes,
case
yes.
in the exam. So inshallah
Very
we have
common,
case.
very common.
Yeah, very common. We have case inshallah in this course. Any other question,
And
please?
yes, Dr. Osama, regarding the diarrhea. So in acromegaly, the most common cause of diarrhea is the one that you said. However, one of my colleague, he had a case in Egypt with chronic diarrhea, and it's found to be severe back pain secondary to acromegaly, and because of excessive amount of painkillers. So can you just elaborate more? Because this case came in Egypt, not this diet, the previous one for my friend.
We discussed this case in this course, if you remember, microscopic colitis.
Yes, but as a part of acromegaly, the chronic diarrhea reasons,
Yeah.
that's what I
very
want.
nice, very nice. In any case of acromegaly, you should rule out polyps, adenopolyps in the colon. This is a very important cause because 10% of patients with acromegaly can develop also adenocarcinoma, colon adenocarcinoma. And we'll discuss it when we discuss acromegaly because this is very important in exam. Inshallah, we have case in this course, very important acromegaly. I will tell you all aspects of acromegaly.
Thank you.
But put in your mind acromegaly associated with colon cancer, adenocarcinoma. So this is very important question to ask about the change bowel habits, about bloody motion in any patient with acromegaly, because about 10% of patients have polyps can transmit it to malignancy. Other question, please. So please put in your mind, yes, doctor, please.
Dr. Hassan, sorry. Just I want you to repeat the difference between secretory diarrhea and osmotic diarrhea.
Secretory diarrhea, the patient usually has large volume of watery stool, unaffected with fasting. So this secretory process usually causes gastrinoma, like in Zollinger Ellison, VIPoma, carcinoid, diabetic autonomic neuropathy. And for malabsorption, usually the patient passes for pale, offensive, greasy stool, or with slim, and difficulty to flush. Usually Zollinger Ellison cause both. For carcinoid, because we have no time, I think, to discuss carcinoid in this course. Carcinoid, it came many times in exam. Usually cause chronic diarrhea with frequent episodes of asthma. So the diarrhea will be chronic, but asthma symptoms and the flushing of the face and these symptoms will be episodic. Very important case. So any patient with a chronic diarrhea, you should put carcinoid also in your differential diagnosis, and you should ask out the patient, do you have any episodes of shortness of breath, whistling sounds in your chest or a noisy chest, and the flushing of the face. It's clear, doctor?
Okay, thanks.
Thank you. So now you should always think about main one in exam, because it came many times. So now if you think about it in exam, you will not forget. You will reach the diagnosis really. This is the, I think, the message from this case today. To put in your mind this diagnosis, main one. They like it in exam, main one and main two. They like it. They like polyglandular, autoimmune polyglandular disease. They like it. Many times it came. So if you put this disease that it came frequently in exam, you will not forget, really. Believe me. We can shift to second case. Dr. Sami, you are here today or not?
Hello.
Hello, Dr. Sami.
Yeah. First of all, sorry for being absent for.
No
3
problem.
days. Yeah.
This is your right, but
Yes, I have really very tough duty. Yeah.
We record case for this reason, really. We record this case because we know that any one of us can be busy with duty and with call. You are ready today? You can take case?
Yes. Okay.
So I'm preparing very nice case for you. And inshallah it will be interesting.
Okay.
But don't kill me. Dr. Sami?
Hello? Yes?
Don't kill me after this case.
Okay. Actually, I have long gap. I feel I'm not concentrating now because I think 3 days now.
But really, this case is very important because it came before last year, and so the important from this discussion not only to practice, also to learn, really. So we are learning, inshallah. This is your case, Sam. You have 4 minutes. If you are ready, Dr. Sam, you can start, please.
Yes, doctor.
You can start.
Okay. Good evening.
Good evening.
Yeah. Are you Mr. Simon, 68 years old?
No, doctor. I'm Adolf. I'm
his
Adolf.
Son. Yes. Yeah. So are you Mr. Adolf?
Yeah, I am Adolf, doctor.
Yeah. Mr. Adolf, I'm Dr. Simon of the medical team in the brain tumor, in the brain clinic today.
Yeah, yes, doctor.
Okay. Are you next of kin of Mr. Sani, Mr.
Yes, doctor.
Adolf?
I'm his son and next of kin.
Okay. And he knows that you are going to discuss with us regarding his condition?
Yeah, doctor. He told me to come here and discuss
Okay.
with you.
Okay. Mr. Adolf, how do you know, how much do you know about your father condition so far?
Actually, doctor, my father has disease called Parkinson disease since more than 10 years. At the early years of disease, my father was doing very well with medication. But unfortunately, since 2 years, his condition worse, even with treatment. The brain doctor tried many times to increase the dose, but really, doctor, he returned to worse few months after adjustment of the dose. Nowadays, the shakiness is persistent all the time, doctor. So I came here today to know what we can do for my father.
Yes, okay. Okay, Mr. Adolf. And what do you expect from our meeting today?
Yeah, doctor, I expect that you will add a new medication can help him.
Yes, okay. Okay, Mr. Adolf. Yes, your father, he has a condition, as you said, which is called Parkinson disease,
Yeah.
which is, there is some deficiency in some substance in the brain which control body movement and in your father. So your father, he has some abnormal movement, some slowness in his movement, and some stiffness, and
Yes.
all that because of this deficiency of this substance. And the doctors and the medical team, he start him on medication to improve these symptoms, and they give him already the maximum dose of this medication.
Yes.
But unfortunately, this medication seems doesn't help too much for his condition. Okay,
Yeah.
okay, Mister. So the medical team and our consultants, which is brain doctors, he decide that your father, he might need some procedure
Procedure?
to improve. Yeah, yes,
Yeah. What is procedure, doctor?
yes, yes, yeah, yeah. This procedure is called deep brain stimulation. Okay.
Yeah.
Yeah, let me to explain for you this
Yeah.
procedure. Okay, if
Please,
you don't
doctor.
mind. Yeah, I'm going to draw for you also. Actually, this procedure, there is they are going to place some electrode in the brain, which in the right side and left side also of
Yeah.
brain of your father, and they are going to connect this electrode with some wire, and to connect it to the battery, which is going to place in his chest. So
But doctor, really, it looks complicated. The surgery, you need to open his brain?
uh, actually, it is not just this. It is going procedure is going to be done under
Yeah.
someone who's expert, and
Yeah.
is going to do. Sometimes it can be done by local anesthesia, which is we are going to give your father some medication to make him relax, and
Yeah.
then yeah, first of all, before this procedure, we are going to do some blood test to make that your some imaging also to his brain, to make sure that your father is safe, to make sure that this procedure is safe to be done for your father. Okay.
So,
Yeah.
doctor, really, it's look complicated, and I'm afraid that this can cause complication. You can tell me, doctor, what complication can be occurred by the surgery?
Yeah, yeah, yes, yeah. I'm going to tell you, and yes, let me yes, let me explain for you first this procedure. Do you get my
Yeah.
message? Yeah.
Yeah, I get it, doctor. I
So
get it that you will connect some
yeah,
electrodes inside the brain, and
yes,
this will connect it
yeah.
with the machine outside. Yes.
Yes, yes, yes. Okay. Yeah. Actually, there is as you know that most all procedure has some bad effect or side effect, but it's
Yeah.
really it seems to be rare. It's very rare. Like it can be there is some bleeding, which is can if happen, it can be controlled immediately by
Yeah.
medical team, and
Yes.
sometimes, yeah, yeah, there is maybe some infection, and also rare it can be some abnormal movement or fits or stroke, which is very rare, really.
Yeah.
Yeah, and sometimes it can be having sometimes displacement of this procedure, which may require another follow up, and we might to need to fix it again. But anyhow, you will be in regular follow up and monitoring the clinic
Yeah.
with our team and brain doctor as well.
So
And
is it curable treatment, doctor?
yeah, yeah, I highly appreciate your concern, Mr. Adolf. Actually, really, it's not curable, but it's going to help us more to control your father's symptoms. And Mr. Adolf, uh, we need also to continue the medication
Yeah.
which your father is taking.
So,
But
doctor,
this person, yeah.
do you feel that this is a benefit that my father can gain from this surgery will overweight the complication, especially we are talking about brain?
Yeah, Mr. Adolf, I have Rashid on Hussein. Actually, the benefit and advantage of this procedure, it's
Yeah.
outweigh the risk. So if we outweigh the risk and benefit, really the benefit is more for your father because the
So,
complication
doctor,
has, yeah.
yeah. But why nobody before mentioned this for us? Why did they leave my father suffering for a long time?
Yeah. Um, Yes, actually, the fairest of all, most of the people with Parkinson's disease, they start them on medication, and
Yeah.
if this medication is helping them, so they will continue on that medication. But in some patients and some cases, the medication is not helping, so that most of them, such people, they shift them
Yeah.
to this kind of procedure.
So
Yeah,
this second step of treatment.
yeah, yeah, yeah. And there is
Yeah.
also some side effect. Didn't tell you. Maybe sometimes there is some numbness and some,
Yeah.
anger or mood changes. Because, but all this is really rare. And as I told you, we
Yeah.
are going to monitor your father and give him proper care of management and follow up
Yeah. Yeah.
regarding what.
So, doctor, can this treatment improve my father walking because he's walking very slow now, and sometimes he looks like freezing?
Yes, yeah, yeah. Highly appreciate your concern, Mr. Adolf. Actually, yes, this procedure is going to help his symptoms. It's going to help his slowness of movement, his
Yeah.
stiffness which he is suffering, and some abnormal movement. All these symptoms is going to be better than now. Really.
Nice. So, my father, his back is curved forward. So, will this treatment improve his posture?
Actually, no, this is, it seems, sorry to tell you that I have appreciate your concern. It seems to be permanent, sorry, damage for your father.
Oh, oh, I'm
Yeah,
sorry for my.
yeah. So we need, also we need to deal with him like that. And I need to ask you some question also regarding
Yeah.
your father's social history.
Yeah. Yeah. Please.
With whom is he living, your father?
Really, doctor, he's living with me.
Yeah. And so who's supporting him at home?
I'm support him also, doctor, and the occupational therapist also help him to manage himself. But really, this
Yeah.
sickness affect him more nowadays.
Yeah, so is affecting his daily activity as
Yeah,
and
yeah, really, really, he cannot also manage
yeah,
himself, doctor.
yeah, yeah. So that's also maybe after this procedure, and we are going also to involve also the social worker regarding that.
Yeah.
And what about job? Is he what is still
No,
is,
doctor, he's not working nowadays.
yeah, yeah. And is he drinking alcohol?
Only occasionally, doctor, at weekend.
Okay, yeah, sorry. And is he smoker?
Only 2 cigarettes, doctor.
Okay. Is he driving?
No, 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 he cannot drive, really.
Okay. Okay, Mr. Adok. As I told you that your father he's taking medication of Parkinson disease, which it seemed to be in the maximum dose, and really it showed no benefit. And so that's our consultant and brain doctors, he decide that we need to put your father in some procedure which is called the brain stimulator, and I have explained for you this procedure.
Yeah.
Do you want to? So can you tell me what did you get from our discussion today?
Yeah, doctor, I get more, but I would ask you also some questions because
Yeah.
I should also explain to my father about this procedure. So, can the treatment improve his speech and drooling of saliva from his mouth?
Yes, it can help some help regarding his drooling of saliva and that, but
And speech can
abnormal.
improve his speech because really since long time he's suffering from his speech. Nobody can understand him well. So can improve it?
Uh, yes, yeah. I think this speak it seems to be also. Sorry to tell you, Mr. Adib, it seems to be also it's permanent damage. Really. Uh, So it's mainly helping in abnormal movement, stiffness, and some swallowing and slowness in his movement.
And this shakiness of hands will improve, doctor?
Yes, it's helped this shakiness too much. Yeah, really. Yeah.
So, doctor, when do you suspect that after this surgery can my father improve? He will improve directly or need some time to improve? Because
Really,
I know, yeah,
yeah, appreciate the concern. Mister, we need to after we fix this procedure, we need to give him follow up after a few weeks, and with doctor, and then uh, he 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 will activate this procedure after that,
yeah.
and he will put him on regular follow up on that. And also, we need to follow him also regarding the procedure. We need to activate the battery every now and then. And this is it will
Yeah,
be
yeah.
in the clinic. Yeah, in the clinic. Yes.
Okay, doctor, I appreciate you. Thank you.
Yeah. Yeah. Mr. Adolf, do you have any concern?
Yes, doctor, if my father can he travel by airplane with this device?
Yeah. Actually, Mr. Adolf, this regarding this question, I need to ask my senior and consultant regarding that,
Yeah.
and I will give you the answer as soon as possible.
Okay, doctor. Thank you. Thank you very much.
Yeah, thank you. Okay. So, Mr. Adolf,
2 minutes. One minute, doctor.
yeah. Do you have any other concern, Mr. Adolf?
No, doctor. Thank you. I
Okay.
understood
So,
everything.
yeah, I will give you some leaflet, and also we need for this procedure, sorry, to take a consent from your father. Yeah.
Yes, doctor. I will try to explain him, and next visit will tell him about this.
Yes, and he will. He can think about that, and if he decide to do it, it's okay. If he doesn't want and want to withdraw at any time, no problem. And also, I'm going to give you some leaflet and on you website, and you can watch some video regarding this
Yeah.
procedure. And your father also can watch that if he would like to proceed. And if you have any hesitance or question, you can contact
Thank
our.
you very much, Dr. Sami. Full mark, Dr. Sami. Really full mark.
Yeah,
Nobody
thank you.
can decrease any mark for you now in this case. This difficult case. Full mark.
Yeah,
Why?
thank you.
Even if you don't explain well this procedure, you will take full mark. Believe me. Yani, I know that most of us have no idea about how can do this procedure. Yes, you are right.
Yeah, yeah.
And in the exam, don't shock it by this case. Like if you have any difficult case, don't shock. They want from you not to know how can do this procedure in details. Really, nobody, the Royal College know that most doctors have no idea about this procedure, how can be done. But you should know what can improve with the procedure and what cannot improve with the procedure. This is the main issue for this one. And this is to manage the patient or the relative concerns that I asked you. Can improve his posture, can improve his he has recurrent hypotension, can improve. This is the issue should know. not necessarily to know everything about in details. طبعا I will explain everything in details, but in exam if you see case like this, not necessarily to know everything, and don't feel that I will fail. No, right? Prepare yourself outside. You know, all of us know most information about this procedure. That yes, improve shakiness of the hands, improve slowness of the movements, but not improve the speech, not improve the posture, not improve the
Yes.
cognitive dysfunction. So my question for you, very nice, doctor. You don't, yeah, really, you ask me about permission. This is very nice. You ask me
Yes.
about next of kin. This is very nice. You ask me about what I know about my condition. Very nice. Expectation. You explain me in details. You answer all my concerns. And also, when I travel by airplane with this device, no problem if you don't know. Yes, very nice answer. I will ask my senior doctor. No, not this is not error. This is very nice. So, this is a case like pacemaker. For pacemaker, what you will answer the patient if he tell you that I will travel by airplane with this device? What you will tell him if the patient has pacemaker?
I will tell him same answer. I don't know if.
Same answer. You know the answer?
Yeah.
Yes, you can travel by plane, but you should inform airport security, and you can carry a card with you that explain he has deep brain stimulation. Because as we know that security, when he passed the security wall or security machine, they will stop because there's alarming from this device.
Yeah. Yes. Yeah.
So he can travel by plane, but he should inform airport security and can carry a card with him that explain he has deep brain stimulation.
Yes. Yeah.
But really you answer all my concerns very well. So my question or examiner questions, what are the legal issue in this scenario?
Yes. Legal issue is the consent
Nice, consent. What are indication
and
in,
yeah.
yeah, you have other thing?
Yeah.
Oh,
Yeah. Yeah. No. 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 Thank you.
no. What the
Yeah. I have no.
indication, what the indication for deep brain stimulation in Parkinson's disease?
Indication. So it's Parkinson. In the Parkinson disease, you mean?
Yeah.
Yeah. It's like tremor
Yeah.
and bradykinesia
Yeah.
and rigidity.
Yeah. So this is the what I should know. A candidate should have, first of all, firm diagnosis of Parkinson's disease. That this is the Parkinson's disease, not Parkinson plus syndrome. Very important point. And the patient responded well to dopaminergic therapy before.
Yes.
And cognitively intact, and have this ability that predominantly related to motor symptoms. So the disability related to motor symptoms, not cognitive. If the patient has any cognitive dysfunction, so cannot indicate for this therapy. So should be confirmed Parkinson disease, not other disease. Should has respond before to dopaminergic therapy and cognitively intact, and has disability that related to motor symptoms. So,
Yes.
if the examiner asks you what's the medical issue in this scenario,
Yeah, medical issue is actually 60 years old man. He's having Parkinson disease for 10 years, and he's on maximum dose of medication for Parkinson like carbidopa, levodopa, and is not which is showed low no benefit. I mean, or
yeah,
yeah. So
and
we
the
need
other
to shift.
and the other medical issue here,
Yes, other medical issue is
deep brain stimulation.
deep venous. I'm sorry. We need to say yes.
So this is what always in scenario, if the patient, if the examiner asks you what's the medical issue, you should mention for him, like we discussed before. If the disease, you should mention the disease. If a
Yes.
procedure, you should mention the disease and the procedure. if there is treatment, you should mention the treatment. So this is the medical issue. You should, يعني, what you discuss with the patient, what the medical issue that you discuss now with the patient. This is the aim from this question. Not only to mention for him that this 60 years old had Parkinson's disease and don't complete. So now you mention only one medical issue. Second
Yes.
medical issue, I discuss also with what you discuss with the patient. You should mention the examiner. I discuss Parkinson's disease with him. I discuss deep brain stimulation with him. Okay. If there
Yes.
is treatment, I discuss the treatment with him. This is the medical issue usually. I discuss the prognosis of disease with him. So this is the medical issue. Okay.
Yes.
And we know that ethical issue, we have 4 ethical issue that we discussed it before. You can mention its name, the names, because to refresh our mind.
Yes. Autonomy, the patient
Autonomy.
right, yeah, and beneficence
Yes.
and malfeasance
And
and
justice.
justice. Yes. Yeah.
And for medical error,
Medical
duty of,
error, duty of control. Duty of
yeah,
control.
this is usually the question can be asked by examiner, medical issue, legal issue, and also ethical issue. And really, nowadays, the examiner asks more questions about the disease and about the investigation. Knowledge rather than this is because really, and why they delete these questions from next year? Because really, they know that especially overseas doctors have no more information about the legal issues that applied in UK. And they mention clearly that not necessary for any overseas doctor to know all the law applied. So only we need to know these issues. Okay? And thank you very much to discuss the consent with him. At least you can mention for him that we need to sign consent by your father before to do this procedure, including all information that will proceed for him, and your father have the right to take his time to read this information, and when he feel ready he can sign, or if he would to withdraw any time before the surgery or before procedure, he has the right also to do it. Thank you, Dr. Sami. Thank you very much. Ready?
Okay. Thank you.
Full mark this today.
Yeah, thank you. Thank you, Doctor.
Thank you, Dr. Sami. So don't forget permission from this scenario. Even I mentioned this permission in the scenario in the my scenario up. I mentioned that this his son take permission from his father, but even that you should ask him about permission. Second of you should explain, but briefly here, not necessary to explain in details about Parkinson's disease. Why? Because the patient has Parkinson's disease since long time, not a new disease. So here, explain briefly, and not necessary to mention all symptoms, all complication of the disease, everything about the disease. No, explain briefly about the disease. And you should mention here, very important to mention, side effect of levodopa carbidopa. Okay, what you should mention, that this medication tends to work less over the time and will lose its efficacy with the time. This is, you should mention for the patient that one side effect of levodopa, that this medication tends to work less well over the time and will lose its efficacy with the time. For deep brain stimulation, I will mention everything about this. Deep brain stimulation is the main type of surgery. It's surgery, not procedure. Used to treat Parkinson's. Usually it's most effective at improving motor symptoms like shakiness, speed of movements, and involuntary movements. Now, when he asks you why nobody told me before about this, tell him that deep brain stimulation may be an option for people whose symptoms are not longer controlled well by the best available medication for their condition. So this is the next treatment. Okay. The surgery will be done by expert doctor, as we mentioned before. And before the surgery, the patient will be, as we mentioned before, for any procedure, first of all, tell the patient what this is procedure or what this surgery. Second, who will do it? The surgery will be done by expert doctor. Then What we'll do before the surgery? Before the surgery, the patient will be assessed carefully, simply. Then, about the procedure or surgery, it's a plus generator. Plus generator is a device, is placed under the skin around the chest or stomach area. It's connected to one or two fine wires that are inserted into specific area in his brain. And this plus generator is switched on, and the electrodes deliver high frequency stimulation to the targeted area. This stimulation changes some of the electrical signal in the brain and cause usually the symptoms of Parkinson's disease. The second point, as we know that deep brain stimulation sometimes can be done while the patient is awake. So this surgery is performed in different way. Either the patient awake for some time during this procedure, or sometimes can be the patient placed under general anesthesia. That means that the person will be fully asleep. Okay. After this surgery, after this surgery, there will be an initial period of healing where the persons with Parkinson may need extra care and attention. After this period, there will be a visit back to the surgical center where the stimulator will be turned on. It will be adjusted until the best possible symptoms control is achieved. This may take some time and may involve a few visits. What's advantage of this procedure or this surgery? First of all, Parkinson's medications can be significantly reduced. Yes, the patient will continue his medication, but really, usually the doses will be decreased. And this will reduce the risk of medication side effects, such as this is abnormal movements, involuntary movements. So this first advantage, that Parkinson's medication can be reduced. 2. It may give you some relief from non-motor symptoms such as sleep disturbance and pain. It may improve your ability to perform day-to-day activities such as feeding, dressing yourself, getting up out of the chair and walking. This will improve your independence. It may improve your overall quality of life. This is very important to mention for him, that what can be improved with surgery, because this patient has this ability. He's dependent now, so that this will improve your independence. What disadvantage? Disadvantage, not improve the speech. And deep brain stimulation will not improve speech, will not improve symptoms like stupid postural hypotension, constipation, memory, and cognitive dysfunction. So these functions will not improve with the brain stimulation, like speech, abnormal posture or stupid posture, postural hypotension, constipation, memory, and cognitive dysfunction, because this is the questions will be asked by the surrogate. My father has his speech is very difficult, nobody can understand him. Does this deep brain stimulation will improve him? I'm sorry to tell you that usually this is type of treatment will not improve the speech, because this is symptoms usually resistant to that treatment. Can improve his abnormal posture, also appreciate his concern. I'm sorry to tell you that this type of treatment will not improve abnormal posture, because it's considered permanent injury and this resistant to treatment. Also for postural hypotension will not improve with this treatment. And memory. Side effects, as you tell before, that also mentioned for the surrogate or for patients, that before to mention side effects, tell him that usually this side effects is usually rare with the good hands, and the benefit that can gain from this surgery or from this procedure will overweigh the complication that usually it's rare with the good hands. And with regular follow-up, we can pick any one of these side effects and manage it accordingly. So always mention before to mention side effects for procedure or for medication, that the benefit overweighs the risk. So the side effects, as we know, bleeding or stroke during the surgery. However, surgical complications are rare. so can cause stroke. You are now do procedure on the brain. So any procedure inside the brain can cause stroke or bleeding, infection, and also the last one that like Dr. Sami mentioned for me, that maybe the patient experience side effects from stimulation that targets a specific area of brain like tingling sensation, pins and needles, involuntary muscle contraction, problems with balance and fall. So stimulation of the brain can cause also fits according to the area that stimulate.
Dr. Hassan, you said relieve many symptoms, improve quality of life in terms of what? The rigidity or the tremor or both?
Movements, tremor, rigidity. Both, three. And gait. The gait will improve. The patient will not develop freezing of the gait. He can improve. He can turn from bed from side to side. Because patient Parkinson disease with advanced disease, even he cannot turn on the bed from side to side. So this type of treatment will improve also his, really he will improve quality of life. I saw many patients with Parkinson disease, really their life changed after deep brain stimulation. He can,
Yes, and
yeah. Yes, Doctor.
and you explained I don't know really actually, Dr. Hassan, because if the patient have the device, it will be in, I saw it one time, the patient have it in the back of the shoulder, or where exactly? I didn't understand.
You see pacemaker for heart,
Yes.
usually in the left upper side of the chest.
Back or front?
Front.
Okay. Left upper chest.
Yeah, like pacemaker. Sometimes, yeah, anywhere we can put it's anywhere, but usually in the chest or shoulder. Usually,
Sure.
this is the site of.
And you
Yeah.
said the procedure need maybe sedation, maybe not.
Yeah.
However, maybe the patient, the surrogate will ask, is it you asked Dr. Sami about the hole in the brain, or I didn't got you from this.
Yeah, we'll do holding, but I will do what can do. This is two type of surgery. I will repeat it.
So
How can do it?
how to explain it in a good
Yeah.
way? I mean, maybe when we tell patient a hole in the brain, he will be like, just
Yeah.
reluctant to do with the son.
First,
I mean, to his father.
First, you are right. Surgery performed in different way. It will either take place under general anesthesia, that means the person will be asleep, or with the person awake for part of procedure. And not will awake for all surgery, for a part for procedure. Yani we can't ask the anesthesia doctor to give the patient anesthesia for short time. We need only for 20 minutes while to do this hole in the skull. After that, please awake the patient. Now the patient will awake. We can ask him how can, and will stimulate this area, and we can ask the patient or see the improvement in front of eye. So this is what happened. But not when we do full surgery without anesthesia, we cannot, because we are doing hole in the skull. We cannot do all surgery without anesthesia.
Yes,
You
and yes, and if he asked like this hole will be done by brain doctor, it's a neurosurgeon, yeah, and then
Yeah.
it put only the wire to the area that not functioning.
Yeah. In
Okay,
the same
sure.
area. I will repeat if you would. How can this is? And then usually it's a device called pulse generator. Device called pulse generator. It's placed under the skin around the chest or stomach area, and it's connected to one or two fine wires that inserted into specific area of your brain. Only this is the explain.
Clear.
Clear. What's now we told for any procedure, what's this procedure or what's the definition? Pulse generator is a device placed under the skin around the chest and connected to one or two fine wires that are inserted into specific area of the brain. And when this generator is switched on, the electrodes deliver high frequency stimulation to the targeted area. This stimulation changes some of the electric signal in the brain that usually cause the symptoms of Parkinson. It's very simple. No need to really to talk in more. Generator connected with wires. These wires will stimulate a specific area in the brain. Surgery can be done in different way. Maybe the patient will be given full anesthesia over the surgery, or sometimes can be awake him during the surgery to know how can doing with this stimulation. This is all. And then you can tell him the advantage that this is will improve, will change the patient's quality of life. Really will change. First of all, we reduce this medication, so we'll reduce the side effects from this medication, will improve his gait, his independence, will also improve his shakiness of the hands, he improve his slowness of the movements. This advantage, unfortunately, let the patient ask you, because he prepare himself. The Korean college give the surrogate these questions. So let him ask you before to mention for them. So mention for him only advantages, and let him ask you what this advantage. So he will ask you.
And it will not work immediately. It will need time to work.
Like need time. Tell him that need time because he will come many times to program it. Need to program. So when will improve after the surgery? Tell him that.
This when will improve. This is the concern.
Yeah. Usually take few weeks after the surgery. Few weeks. It may take several months to fully program the stimulator and adjust Parkinson's medication to get the most benefit from this treatment. So it will take weeks to months. Is it a cure treatment? Is it not a cure treatment and does not stop Parkinson's from progression? Also does not stop the disease from progression. It's very important. If the patient tell you that, doctor, this surgery means that I will not develop more symptoms with the future, no. I'm sorry to tell you that this is not a cure treatment and does not stop Parkinson from progression. This type of treatment will improve the symptoms that your father now suffering and improve his quality of life, improve his gait, improve his independence, like this. Really, this case came in Diet 1 2019, and most of candidates shocked. I don't know why. They have the right to shock it, really, because really nobody know much more about deep brain stimulation. So the candidate feel that this case very difficult that time, and they wrote on all websites, and that's this difficult case, very difficult case, and they have the right, I think.
Sorry, sir, I have a question.
Yeah, please, doctor.
Sir, follow-up is in weeks. So if you ask how often do we follow up? Do the patient follow up?
Yeah, this patient will follow up with the brain doctor, not with neurosurgeon. Later on, they will follow with the brain doctor. So now we'll keep him on the same medication that the patient taking now. But this, because this is device, need time to be programmed. Yani we mean that every visit will change the stimulation, maybe increase it to feel that patient symptoms improve with the time. Then we will decrease the dose of medication to the minimum dose that patient have no symptoms. Well, this is the brain stimulation.
Okay. So each follow-up, the device will increase and the dose of the medicine will decrease.
Will decrease. Yes, you are right. Like this.
Okay, sir. Thank you.
Thank you. Up to reach to the minimum dose of medication, that time house will keep him on the same program. And with the future, maybe later on will increase the stimulation, the frequency of stimulation. And each visit will observe this machine, and this is a response. Any question, please? Okay, we can go to the third case, Dr. Abdullah, I think, today.
No, sir, that's me.
Dr. Rahina, sorry, because the mobile not front. Okay, so this third case, station 5. You have 2 minutes, Dr. Rahina. We can start, doctor.
Sure, sir. Hello, good morning.
Good morning, doctor.
My name is Dr. Faruqi. I am one of the doctors in the neurology clinic. Are you Mr. Thompson, 45-year-old?
I'm Thompson, doctor, yes.
Okay, nice to meet you.
Thank you.
So, Mr. Thompson, I've been asked to talk to you and do your examination. Is that fine?
Yeah, please, doctor, please.
Okay, so what brought you here, Mr. Thompson?
Doctor, I have this shakiness in my both hands. It has been before for probably 5 to 6 years, but nowadays increase over the past couple of years.
Okay, so it's increasing. Can you
Yeah,
tell
yeah.
me, were you fine all 6 years back?
Yeah, it suddenly 5 to 6 years. Before that, I have no any shakiness.
Okay, so is it on rest or when you're doing anything,
No,
when you're
doctor.
doing,
When I'm doing, when I'm
okay,
hold anything like when I'm drinking the tea or like this.
okay. So does anything makes it better?
Really, doctor, I noticed that improve when I drink alcohol on weekend.
Okay. And does anything that makes it worse?
Yeah, doctor, when I'm under stressful or I'm anxious, I feel it's become more.
Did you ever take any medication to get it better, to make it better?
I didn't try any medication before.
Okay. Okay. And any head injury recently?
No, doctor, I have no head injury.
Do you have movement of head along with this?
Really, doctor, my wife noticed that I have also shakiness in my head recently.
Okay. Can you describe this shakiness to me
Doctor?
a little bit? Can you tell me about this shakiness? Is it moving forwards or like rightwards or anything like that?
Yes, I feel that my head like have titubate from one side to other side.
Yeah. Okay. Okay. Any headache associated?
No, doctor, no headache.
Any problems with your mood or memories?
No, no, it's okay, my mood, doctor.
Okay. Any change in your vision?
No, doctor.
Change in your hearing?
No.
Any changes in your speech along with this?
No, doctor, my speech is okay.
Okay. Any changes, difficulty in swallowing?
No.
Okay. Any weakness that you've noticed along with this movement?
No weakness, doctor.
And does it get better when you reach to the when you reach and when you pick up? Does it get better, this tremor?
Yeah, become better a little bit, doctor. Really, it's more when I am holding the cup of tea or like this.
Okay. So can I examine you, Mr. Thompson?
Please, doctor.
Okay. I want to check your hand first.
What you will check, tell me.
I want to check the movements when you're resting.
No, no rest tremor.
Okay. I want to check your pulse.
Pulse regular, no atrial fibrillation.
Okay. I want to hold, make you hold your pen and write something.
Yeah, he has tremor when he's writing, and his right handwriting is large letters.
Okay. I want to go up and look towards your head, movement in your head.
What you will examine his hands, doctor, also else.
Um,
Now you are examining the hands, you should examine if he has tremor at rest, and then outstretched hands, and then you should do finger, nose,
yeah. Finger nose testing. Yes.
finger, nose, and then you should examine also for rigidity, to tone, examine the tone also, very important. And then same easily for the power, only tell the patient to outstretch the hand, so you will feel that there is no any weakness. And yes, also what you will examine for him in here in hands.
In hands, other than this, the motor movements.
You can, yes, you can tell him that to give him a cup of tea or like this to or a glass of water.
So I already
To
I already
drink.
checked with the hands, the movement, the
Yeah. Then when we'll
eye
go,
movements. Yeah.
eye
Then
movements,
go up.
very nice.
Yeah. Yeah.
Very nice. Eye movements. What you will examine for what? What you look for?
Except for nystagmus. I would,
Non-nystagmus.
okay. I would look for the head movements. If
Head
you have
movements.
any.
Yes, there's fine titubation. Fine titubation.
Yeah. Okay. And then I would go below and I would check for any heart, any heart racing of hearts.
Racing of the heart. You examine the hands, no racing of the heart. Yes. What
Okay.
else?
Okay. In that, I want to check for cerebellar dysfunction. I want to check for any a finger nose shell that I've already done. This diabokinesia for rapid
Nice.
movements of hand,
Very nice.
and
Very
then
nice.
I would want to him to check his gait,
Very
and
nice. Very
and
nice.
I
He
would
has
want to check. Yeah.
normal gait.
Okay. I would want to check for his if he stands still, and I want to check if close his eyes and check for his movements. And uh,
Yes.
yeah,
Very
yeah.
nice, doctor.
So and shakiness of legs.
No chickens of the legs.
That's it. That's it.
Yes. Very
For
nice.
now.
Examination. Very nice.
Okay. Okay, Mr. Thompson. Anything? Any drugs that you've been taking?
What's my concern?
Any drugs
What?
that you've been taking? Any drugs that you've
No,
been
no,
taking,
doctor.
Mr.?
No, no, doctor. I don't take any
Do
medication.
you smoke, Mr. Thompson?
No, no, not smoking, doctor.
Okay. Do you drink alcohol?
No, doctor. Only on weekend, as I told you that I feel also
Okay,
this
that's
improve my shakiness.
okay. That's great. How is it affecting your work, Mr.
Really,
How do you
doctor.
work?
I'm working as engineer and affect me especially when I'm using computer.
Okay. So I would advise I would involve the department, the concerned department, occupational therapist, occupational health worker who can help you in this regard because this might be affecting
Yeah.
your life much. Okay.
Thank you.
And Mr. Thompson, so what are your concerns?
Really, doctor, I saw the program on the TV about Parkinson's disease and I afraid that can be Parkinson's disease.
Okay. So just one thing, Mr. Thompson, any family history of similar condition?
No, doctor, nobody have like
So,
this.
Mr. Thompson, what I got from your history and I got from your what you have told me is that you have a condition called as essential tremor. This is
Yeah.
when there are some signals in your brain that are affected, and you have this shakiness in your hands whenever you're doing something. Mostly whenever you're doing something, this involves even your head. But this is not Parkinson's, as I would like to mention. And we have management options. We have a drug called propranolol, which can help you in this regard. And even yes, you're right. This alcohol makes it a little better. And any more concerns that you have, Mr.
Thank you, Dr. Rahina. Thank you very much. You are very great today. So, Dr. Rahina, but you forget something very important in this case. Why don't ask about symptoms of hyperthyroidism?
I forgot about weight loss.
Very, very important hyperthyroidism and pheochromocytoma. This is the two diseases you should ask any patient with tremor. Symptoms of hyperthyroidism, always put in your mind hyperthyroidism and also pheochromocytoma. What's your diagnosis now?
Essential tremor.
Essential
Because
tremor.
it gets better with alcohol, and he has slight titubation along with this. And when on
Yeah.
examination, when his hands were seen, there were
Outstretched.
no tremor. Yeah, outstretched hand, there were no tremor.
So
But ruled out.
if he has family history,
Yeah.
you will change the name of this.
Change the name of
Familial tremor. This disease
familial tremor.
it's called essential tremor or familial tremor, both. But usually we mention essential tremor if the patient has no family history, but we can mention also familial tremor if there's family history. And we know that not all people have family history, only about 60% have family history. So this is very important. So if there is no similar family history, so you should not change your mind, you should not change your diagnosis, very important in the exam. It's not necessary for essential tremor to be with family history, very important. So what investigation you will do for him?
I would do the baseline investigations. I would do complete blood count and
Yes.
Electrolytes, and I would also do LFTs just to rule out if this is not flapping tremor. And I would like to do the thyroid function test to rule out hyperthyroidism.
Very important.
I would also like to do check for pheochromocytoma with urine, 24-hour urine for metanephrines and non-metanephrines.
If the I
This
said,
is basically a diagnosis of exclusion. So I
yeah,
would do,
yeah.
yeah.
If a clinical history suggests that this patient has pheochromocytoma, you can proceed. But if the history not suggested,
Okay.
no need for pheochromocytoma because
Okay.
we know it's
Costly?
cost, yes. But
Yeah.
for thyroid function test, you can do it, no problem. Okay. But for pheochromocytoma, tell the examiner that if the history suggests, like the patient has episodes of hypertension, flushing, headache, like this, okay. And also like this, if we have sometimes
Hello? Hello?
teenagers,
Yeah.
okay, according to history. طيب,
So I think I missed the middle part. I didn't hear you.
yeah, I mean, if the history suggests Wilson disease, that young patient has other signs like abnormal postural dystonia or chorea movements like this, you can also, besides the tremor, we can proceed for Wilson disease. طيب, is
So,
there any
so sorry to interrupt, but
brain?
Wilson's is a little earlier, no? It's in his 20s,
Yeah, yes, yeah,
longer from.
young, should be young patient. Yes, I mean, yes, I told in teenagers age. طيب, treatment, how can manage this patient? How can treat him?
So the best is first is non-pharmacological and pharmacological. Patient education is important, and along with this, physiotherapy, and with this, propranolol is a good drug which has a good effect on essential tremors. Yeah, that's it.
What other medication if the patient has contraindication for propranolol? What you can give him?
A calcium channel blocker?
No.
I don't remember. Topiramate? I don't remember.
Brimidone.
Yeah. Sorry.
And also there are other options I will mention for you. Topiramate. Topiramate
Topiramate,
can
I
be
just
used.
said, yeah,
Gabapentin.
topiramate. Yeah.
Yeah, gabapentin also, benzodiazepine, but usually not used in this tremor. And Botox
Hand
injection.
splint.
Also
Hand splint is also
Botox.
important. Yes.
Yeah, very nice. Very important this. But if the patient has severe essential tremor and not improve with this treatment, what we can do for him
Botox,
other than
or we
Botox?
can release the deep brain stimulation that we just talked about.
Very nice, doctor.
Yeah.
Stereostaxic, thalamotomy, and
Thalmotomy.
thalamic deep brain stimulation. Thalamic deep brain stimulation. Very nice, doctor.
Yes, sir.
Hina. So, how can classify the tremor?
So we can classify by doing intention and resting tremors. Resting tremors are usually intention tremors are usually due to anxiety or this essential tremor, and resting tremors.
Yeah.
So resting tremors can be due to hyperthyroidism, and
No. Hyperthyroidism usually cause like this, like
yeah, intention tremor.
essential tremor. Yeah.
So
So,
I can't recall.
thank you, Dr. Hina. Really, you are great today, but only for any tremor, don't for, yani you see, I feel when you take history from me, I feel that you ask me about Parkinson plus syndrome, and very important.
Yes, I did.
You
Yeah.
ask me about Parkinson. Yeah, I feel that you ask me if I have.
I knew about hyperthyroid, but
like,
I didn't ask on you on examination because I said if you have any weakness. So I had this hyperthyroidism, but I forgot to ask about weight loss.
Yeah, very nice weight loss and also weather intolerance. And when you examine the patient, you should in the hands look about sweaty hand, very important, about the pulse to rule out tachycardia and atrial fibrillation. And also you should look to the eyes if the patient has any manifestations of Graves' disease.
Level of
Very
nutrition,
important point.
right.
Yeah, because really tremor is very common symptoms of hyperthyroidism. Thank you, Dr. Hina. First of all, I will answer these questions. Yes, thank you. How tremor classified? Very important point. We have two types of tremor. Rest tremor, action tremor. For action tremor, can be divided to 3 or 5. So we have rest tremor, action tremor. Action tremor, we have postural tremor, usually presents while maintaining postural against gravity, like when they ask the patient to outstretch his hand. How can know from history that this patient has postural tremor? Ask him, this shakiness of the hands come when hold the objects with your hands? Yeah, usually when the patient hold anything in his hand, when he hold a cup of tea or hold anything, he will feel tremor. When you how can examine this for postural tremor? Outstretched hand. So action tremor divide to postural tremor present while maintaining posture against gravity. 2. Kinetic tremor occurs during voluntary movements. So how can ask patient clinically for kinetic tremor? Does this shakiness increase when you try to drink water? So when the patient doing voluntary movements, so this is kinetic tremor. And intentional tremor occurs with target directed movements with increase in amplitude and termination of the movement, and we know that kinetic tremor and intentional tremor, this is specific for usually cerebellum. And we have task specific tremor. This is usually related to one task. The patient has tremor only when he's writing or he is playing music, like this. And we have other types. This is very rare. Isometric tremor. This is what's called orthostatic tremor. And this tremor occurs only when the patient stand on his feet, so he will feel that his legs, shakiness in his legs, and can be fall down because this shakiness. This is rare. Don't worry about this. Forget it. Okay. So we have rest tremor in Parkinson's disease. Usually rest tremor specific for Parkinson and Parkinson plus syndrome only. Can be seen in essential tremor? Yes, can seen, but usually this is not the main form. This is usually in patient with the essential tremor, usually mainly have postural tremor. But yes, with advanced of the disease, you can find all types of tremor, but usually only postural tremor at the beginning of the disease. Discussion. How can approach patient with tremor? First questions, as we know for any symptoms, onset, course, duration. Then, is it unilateral or bilateral? It affects one limb or both limbs? Very important question. Because if we have tremor affect one limb, you should think about brain disease, space occupying disease, like tumor, like stroke, like bleeding. So is it unilateral or bilateral? We know Parkinson's disease also for wrist tremor affect one side rather than two sides. Yeah, the patient usually in Parkinson's disease have one side predominant more than the other. Maybe has bilateral, but really always asymmetric in Parkinson's disease. In essential tremor, usually symmetric. So, onset, course, duration. Is it unilateral or bilateral? Is it at rest or is it postural? As I told you, ask patient, is it more when hold something in your hands? Or is it intentional? Is it more when you try to eat or drink? Then, which part of the body affected with this shakiness or tremor? Hands, legs, jaw, tongue, voice, head. You should ask about this. Why? Because as we know, head tremor, it's seen patient with essential tremor. Why? Jaw and chin usually seen in the patient with Parkinson's disease. So I will repeat. Head tremor seen in patient with essential tremor, not Parkinson. While jaw and chin seen in patient with Parkinson's disease. Provoking factors. Do you feel that is there anything in particular can increase your symptoms? Like always mention examples for the patient, like drinking coffee, like tension or stressful. Okay? All types of tremor, but especially essential tremor exaggerated can increase with tension. I will repeat, all type of tremor, but especially essential tremor can aggravated by anxiety, by caffeine, by emotional stress. Is there anything in particular can improve your symptoms? Like when you sleep, all types of tremor also improve while the patient sleep, and alcohol usually improve the symptoms of essential a tremor. This is very important. And please, when you ask about alcohol, maybe the patient not drinking. So first of all, before to ask him, is there anything you ask him, is there anything in particular can improve it? I'm sorry, if you are drinking alcohol, okay, or ask him, do you drink alcohol? If he tell you yes, you feel that improve with alcohol drinking. And don't first ask the patient if he drinking or not drinking. Maybe the patient not drinking alcohol. Other symptoms, as we mentioned, this case, a neurological case. So you should ask about other neurological symptoms, like for Parkinson's disease. Now I will mention everything about a tremor because sometimes tremor it's common to present in the station 2. In station 5, it's easy to know which type of tremor that the patient has. Why? Because the patient in front of your eyes. So you know now when you see the patient, you can recognize is it Parkinson's disease by see the wrist tremor. But in station 2, you have no patient. So it's difficult sometimes. So you should depend on the history only. So after you analysis of tremor of the symptoms, now go to the neurological manifestations. What the symptoms of Parkinson's disease? So you ask the patient about slow movements, stiff limbs, difficulty to turning in the bed, recurrent fall down. For Parkinson plus syndrome, we have multi-system atrophy. What the features of multi-system atrophy? Symptoms of presyncope and syncope, and urinary symptoms like frequency, hesitancy, incontinence, constipation, impotence. Autonomic symptoms. So very important for multi-system atrophy. Only you have to ask about autonomic symptoms like presyncope and syncope, and as we mentioned, urinary symptoms like urine incontinence, constipation, and impotence. For progressive supranuclear palsy, you have only one question. Do you have recurrent fall down? Usually patient with progressive supranuclear palsy, the patient have recurrent fall down, especially backward fall down. And usually progressive supranuclear palsy in examination, you should examine eye movements for supranuclear palsy. Dementia with Lewy body, how can know it? Usually the patient has visual hallucinations. So you can ask patient, do you see image that the other people cannot see? This is very important. And as we know that Lewy body symptoms, usually the patient has cognitive impairment before or within 1 year of developing Parkinson's symptoms. As we know, Parkinson's disease can associated with dementia, but usually will come late. So if the patient has developed symptoms of dementia within 1 year after Parkinson's symptoms, so this is Lewy body syndrome. Then cerebellar syndrome or cerebellar symptoms. Ask patient about vomiting, nausea, vertigo. Then don't forget, as we mentioned, ask about signs of hyperthyroidism and pheochromocytoma. Don't forget it. Then medication. Very important for tremor, drug history. Why? We have medication that can induce intentional tremor like anti-epileptic, like phenytoin, sodium valproate, and lithium. Lithium, it came before in exam many times as a cause of tremor. Lithium toxicity. Chronic lithium toxicity that the patient is taking lithium for a long time and not following with his doctor and has now a tremor. 2. Drug-induced resting tremor. Usually the drug caused Parkinson's symptoms, antiemetic like metoclopramide, prochloromazine, and neuroleptics like haloperidol. And we have drugs can cause exaggerated physiological tremor as sympathomimetics like salbutamol, theophylline, levothyroxine. So medication can cause exaggerated physiological tremor, and this is common in a clinic. Salbutamol and theophylline and levothyroxine. Recreational drugs like cocaine and amphetamine and anabolic steroids all can cause exaggerated physiological postural tremor. Alcohol consumption, very important. Because alcohol, small amounts of alcohol can relieve the tremor as an essential tremor, as we mentioned, but chronic excess alcohol consumptions can cause to cerebellar syndrome, and the patient will have intentional tremor rather than postural tremor. And sometimes, as we know, that tremor can result of alcohol withdrawal, and this is also come in exam before, alcohol withdrawal symptoms, especially tremor. Family history. Family history is critical. Why? Because as we know, 60% of patients with essential tremor has positive family history, so that diagnosis familial tremor. Last point, how can examine patient has tremor? Either in station 3, a neuro examination, and this is common to see patient with Parkinson's disease in station 3, or in station 5, patient has tremor. First of all, inspection. When you see enter the exam, see the patient. Parkinson's disease, he will tell you, I have Parkinson. The face of Parkinson's disease, he will tell you, I am Parkinson's. As we know, that expressionless face, mask-like, you will see the patient like mask, his face like mask, no expression features. So if first of all, inspection. Then try to look to the hands. Most patients with Parkinson's disease will try to hold their hands to disappear the tremor, and this is very important. And they learn him. The examiner learn Parkinson's disease, please hold your hands to disappear the tremor. So you should look for him. If he hold his hands by his leg, sometimes he put his hands under his leg, under his thigh, also to fix it. So if you see the patient fixed his hands, so you should know that this patient has wrist tremor. So please, when you see enter the exam, look to the face. You will see mask-like face or expressionless face, and sometimes you can see head titubation. Head titubation, as we mentioned, this is pathognomonic for essential tremor. And look to the hands. If you see wrist.
What's head decubation, doctor? Head decubation.
Head titubation, you see the heads move from one side to side, and this is head tremor. Titubation, titubate, like the watch. If you see the
basically yes, no.
Yeah, yes, you are right. Like
That's
yes,
the best thing to.
Yeah.
Yeah.
You see that heads like yes, no. Yes, you are right. So, then go to the exam. First of all, with a patient with the tremor, start with hands. Check the pulse to rule out tachycardia and atrial fibrillation in patient with hyperthyroidism. Sweaty hands, this can be seen in patient with, and palmar erythema, this can be seen in patient with hyperthyroidism. And comment about the character of tremor. It's fine or coarse tremor. And see if it's resting or action or kinetic. As we mentioned, see if the patient has wrist tremor, then ask the patient to outstretch his hands in front of his hands, and the fingers should be separate apart. Okay, this is very important. If the patient close his fingers, ask him to separate fingers apart. After that, you ask the patient to do finger nose maneuver to see if he has intentional tremor. Then see if the patient has rigidity. Examine the rigidity. We know that in Parkinson's disease, patient has cogwheel rigidity at the level of the wrist and lead pipe rigidity at the level of elbow. And then examine the power. Why the power? Simply no need to examine the power in details like in the patient with weakness or like this. Only to see if the patient has weakness, because sometimes neuropathy can cause tremor. Very important point. Then you can examine the handwriting. As we know that Parkinson's disease will has micrographia, while essential tremors has macrographia. The handwriting in essential tremor will be large letters. Then go to the face. Very important in the face to examine for eye movements. Failure to upward gaze initially in progressive supranuclear palsy. See if the patient has nystagmus for cerebellar disease or Parkinson plus syndrome, and see if the patient has manifestations of thyroid disease, thyroid eye disease. Then, last point, go to the gait. Let the patient walk. See if the patient has any freezing gait, has any stupid posture, poor arm swing, small shuffling steps. This is indicate Parkinson disease patient. See if the patient has ataxic gait or board-paced and difficulty with tandem walking. This is usually in cerebellar ataxia. Any question, please? Any question, please?
Sir, can you tell about isometric tremor that you told? Just a little bit about that.
This is isometric, I mean, isometric tremor, usually this is the tremor, what's called also orthostatic tremor. Orthostatic tremor, this tremor usually in the lower limbs, in the legs when the patient stands from the bed. He told you, I feel that tremor in my legs and tendency to fall down. When he start to walk, disappear. This disappear when the patient start to walk. Only appear when the patient stand on his legs. This is isometric tremor.
Okay, thank you, sir.
Thank you. Other question, please?
Hello, Dr. Hassan.
Yes, doctor.
Can you please tell me about the examination of the Parkinson patient?
Yeah. If you go to the station 3, exam,
Okay.
you will see it's mentioned above the patients. This patient has slowness of the movements. This patient has recurrent fear fall down. Please examine the patient as appropriate. Like this, the instruction will be in the exam. So here, because the history told you that patient has fall down, recurrent fall down, or the patient has tremor, or the patient has slowness of the movement, so now you suspect that this patient Parkinson. And first clue for you, that patient, you see his face, you will see that this patient has expressionless face, mask face. Please, if you don't see before any Parkinson disease, Google it on the Google and you will see his face. It's very clear. Really, you will notice that how can expressionless face appear. Then, most likely the patient with Parkinson disease in exam-wise will try to fix their hands to disappear the tremor. So you will see the patient either fix his hands by other hands or fix it by put it under his thigh.
Yeah, holding hands together.
Yeah, he tried to hold it to disappear this tremor. As we know that usually the tremor will disappear with fixation. So, when you see these clues by inspection first, so this inspection important for expressionless face and to see the type of tremor. In exam-wise, now you know that this patient has Parkinson. Go to his face first. I advise you to start with face. From up to down, better for you. Okay? In his face, first of all, see if the patient has expressionless face, as we mentioned now. And if he has drooling saliva, like patient Parkinson disease, and see if he has also tremor affect the face, as we mentioned, titubation, head titubation. If the patient has jaw tremor, and ask the patient to open his mouth to see if he has tongue tremor. And also see if the patient has, this is, will not take seconds, huh? Actually, examination of Parkinson disease patient in exam will not take 5 minutes. Really, within 3 minutes we'll finish, I'm sure. So, see is also, let the patient open his mouth to see if there's palatal tremor. This is lesion in dentatorubral pathway. Forget it, but see if he has tongue tremor. Then check the eye movements. Eye movements you check for 2 reasons. For nystagmus that can be seen in patient with cerebellar syndrome, and for also failure of upward gaze. As we know, yeah, progressive supranuclear pulsing. And then look to the sign of thyroid disease. If the patient has proptosis, if he has lead lag, lead retraction, this is very important. Now I finish the head, the face. Go to the hands. Hence, important to check the pulse to see if there has any tachycardia as symptoms of hyperthyroidism. Sweaty hands and pulmonary erythema also as symptoms of hyperthyroidism. And then see the tremor. Ask the patient, please rest your hands on your thighs. Tell them like this. Please rest your hands on your thigh.
Okay, Dr. Hassan, can you tell them to rest the hands over the pillow?
Or over the pillow. Yes, you are right. Okay. And here see if the patient has rested tremor. Will be very appear, and usually in Parkinson disease patient, the tremor will be asymmetric, will affect more side other than two sides. Very important. So see the tremor, is it coarse or fine? And we know that Parkinson you have bell rolling tremor. Now you see the tremor. Then tell the patient to outstretch his hands in front of his and tell him to separate his fingers. Make his fingers apart. Because the patient most likely will close his fingers. So ask him to open his fingers. Okay? See if he has postural tremor. So rest tremor, postural tremor. Then ask the patient to do finger nose maneuver to see if he has intentional tremor or yes, intentional tremor. Okay, then you can ask the patient to.
But intentional tremor is not a feature of Parkinson's disease, right?
No, intentional tremor not manifestations. This is cerebellar syndrome. But you should examine the patient fully now. Intentional tremor, because why? Because as we know, we have disease that cerebellar tremor can cause all types of tremors, what's called Wilms disease, can all type of tremor, and usually it's unilateral. So for this reason, maybe this patient has no Parkinson. This patient, if we suppose he has no facial features, maybe he has cerebellar tremor. So you should examine all type for tremor. So rest tremor, then postural tremor, ask the patient to outstretch his hands in front of his body. Then ask patient to do finger nose maneuver for intentional tremor. Okay? Then you should examine the tone. How examine the tone? We should examine the tone at the level of the wrist to see if the patient has cogwheel rigidity, and at the level of elbow to see if he has lead by rigidity. After tone, examine the power. No need to examine the power like patient with stroke. Only you can ask the patient to examine the power at the level of the elbow by extension and deflection. Okay? To see if the patient has weakness. Because as we know sometimes that Parkinson's symptoms or tremor can due to stroke, or the patient has maybe polyneuropathy, he has a decreased tone in both limbs. After examining the power now, and we go to the exam all cerebellar sign like rapid alternate movements, like this diadochokinesia. Okay? Examine this also because we have tremor now in the case of tremor. And we know that rapid alternate movements and diadochokinesia will be slow in patient with Parkinson's disease, while will be in patient with cerebellar tremor will be irregular, as we know. Patient with Parkinson's disease, this alternate movements and diadochokinesia will be slow, while patient in the cerebellar syndrome will be irregular. And then handwriting, give him paper and let him write. Usually handwriting will patient in Parkinson's disease micrographia, while in patient with essential tremor macrographia.
Okay. Is there any role of testing the function in patient with tremor?
And I advise you, if you find, and really always look to the table. You will put the glass. They will put the glass water because they need you to examine the
functional ability.
Yeah.
Yep.
And then
okay,
go to
you said handwriting micrography.
Yeah. Handwriting also, handwriting is examine the function, as we know. Is part of examine the function. So don't forget handwriting for two reasons. for functions and to know the type of handwriting. As we know, small in the patient with Parkinson's disease, while it will be large in the patient with essential tremor. And then ask the patient to stand. طبعا ask him, you can walk, can you walk? If he tell you yes, I can walk, doctor, let him to walk, and look for the signs of Parkinson's disease like freezing, like stupid postural, and you should comment, you should mention for the examiner that I noticed that this patient has a stupid postural, poor arm swing, as we know that patient with Parkinson also has poor arm swing when he's walking, small shuffling steps, okay, and also if we can see broad based gait in patient with cerebellar syndrome, and you can examine also tandem walking, because also this is affected in patient with Parkinson with cerebellar syndrome. Last of thing, tell the examiner I will do retropulsion maneuver. This is, you know how can do it. You can stop behind the patient and fix him and put your hands in front of his shoulders and try to push him behind. But this is usually take the permission. Don't do it. Don't do it without permission. Why? Because this can sometimes cause fall down for the patient. And don't do it this. But tell the examiner, I will do this is retropulsion maneuver. You should mention for him to know that how can do it. Okay? But don't do it. I advise you don't do it. And only take permission, because this is sometimes can cause a problem in the exam. So, but take permission for this. And now you finish exam. Tell the examiner after that, I would to examine cognitive function for this patient by doing mini mental state examination, and also I would to check his blood pressure in lying position and standing position to look if this patient has orthostatic hypotension. This is very important. This is a part of examine any patient with Parkinson's disease. But this is, you will not do it, but you should mention for the examiner. Like in GI symptoms, you can tell the examination, I would to complete my examination by do rectal examination or PR.
Okay.
Also here, you should mention for the examiner like this.
Okay, got it. Thank you. But is there any role of telling him to say something like constitution?
For talking, yes.
Yeah.
First of all, when you start the talking, how can be? Yes, I forget it really. When you start the exam, you will grade the patient. So here you can ask him same questions. How are you? How do you feel now? I would examine you. Let him talk something. Yes, you are right.
So no need to ask something utter some specific pronunciation. Just telling the regular sentence, right?
Yeah. You will feel. You see. Parkinson's disease patient, when he talk anything, you will see his. You can see his talking. How is the talking is slow.
Doctor.
And, yes, doctor.
Well, actually, I'm asking because some of the patients really well controlled. Actually, my friend got the case in UK, and the patient was very well looking to the degree that he told me. Actually, he passed. Why? He told me, I felt like nothing could explain the case apart from Parkinson. However, there were nothing of this. So what do you think, Dr. Osama, if we are suspecting and we cannot, because no tremor, no rigidity, what do you think about this? I'm afraid of this, really.
You see, doctor, I will tell you something. All Parkinson patients, you will find cogwheel rigidity, even if it's taking full medication. But how can see this? This is important question. Thank you, Dr. Hassan. When you see that the patient has now, you look to hands, you feel that no tremor. Patient with Parkinson's disease now is taking his dose now, this moment. So you really will not find tremor now. What you will do? I will do something that I will ask patient when I examine the hands for cogwheel rigidity. I will tell him to hold something in the other hands. When he will do this, I will see cogwheel rigidity.
Sure.
You understand me? When you
yes, doctor, it's from a neurologist, so it's very clear, really.
and this is what we'll do in the exam. And really, this is mentioned in the Oxford book. This is for how can examine Parkinson patient.
Can you
mentioned
repeat,
clearly.
sir? Can you repeat, sir?
The other point also, the other point important, face. Medication will not change the feature of the face, but really you should see many face. You should now open the Google and see Parkinson patient face. You will see the mild, moderate, severe. Even if you see many pictures of the mild Parkinson face, really you will recognize him. You will see like angry face, no features in the face. Yeah, really, you will see that angry face. Here you will feel that this patient has also Parkinson. And the instruction that it's written for above the patient, usually they will write for you, this patient has difficulty of walking, or this patient has recurrent fall down, or they mention this patient has slowness of the movements. Please examine as appropriate. When they mention this is Parkinson. Nothing else. They will not. It's difficult to bring other cases like progressive
Yes.
supranuclear pulse. It's very rare, and usually the patient
Thank
has
you.
dementia. Yes, it's very rare to bring these cases.
Yeah. Thank you so much, Dr.
Thank you,
And
Dr.
can you please mention the point where we can differentiate between Parkinson disease and the other Parkinson plus
Yeah, you are right.
syndromes?
We have other Parkinson disease patient. We have first of all what's called multi-system atrophy. Usually, this is the patient has autonomic features like syncope symptoms, like urinary symptoms, like frequency, hesitancy, incontinence, and also they have constipation and impotence. This is autonomic symptoms, as we know. So, multi-system atrophy, the patient has autonomic features. For progressive supranuclear palsy, usually the patient has recurrent fall down, retrograde fall down, and usually progressive supranuclear palsy, the patient will tell you, I have visual disturbance. Okay? Dementia with Lewy body, usually the patient has
No.
hallucinations.
Can you please repeat from the second one? After the multiple system
Prog-
atrophy, there was some
prog-
sound problem.
progressive supranuclear palsy. The
Okay.
patient has recurrent retrograde fall down. The patient will tell you, I have fall down when I'm climbing stairs. Okay? And the patient has visual disturbance. Okay? And usually they have emotional lapidity. Dementia with Lewy bodies, the patient usually have visual hallucinations. So you can ask him, do you see images that the other people cannot see? And usually dementia with Lewy body, the symptoms will be fluctuating. Yeah, the family will tell you that I feel that sometimes my patient become better and sometimes he see these hallucinations. And important point, dementia with Lewy bodies come in diet 1 2019 in station 2. Dementia with Lewy bodies. The patient has tremor, has slowness of the movements, has visual hallucinations, and he has also fluctuating symptoms. The family tell you that he becomes sometimes better and sometimes deteriorate. Then ask about cerebellar, nausea, vomiting, vertigo. Vertigo, very important. Then ask about hyperthyroidism and pheochromocytoma. Medication, as we mentioned, drug history, very important, and family history, very important, and alcohol consumption. If the patient has excess alcohol consumption, this causes cerebellar syndrome, or if the patient stopped to drink alcohol, so this can cause alcohol withdrawal symptoms.
Okay. Thank you so much.
Thank you. Any question, please?
Really, Dr. Hassan, thank you. This is a station 3 and 5. It's not 5 only. Really, thank you.
Really, I prepare like this. I prepare this case to be inshallah next. And inshallah, in future, I prepare to do also a video how can examine Parkinson disease. Inshallah, in future, I will upload also on YouTube.
It's common, really, it's common and clear. You made the
Very
examination more easy in station 3. Very common, yeah.
Yes, it's very common. Parkinson to appear in the station 3. Yes, you are right. Very, very common. Any question, please, before to go to a fourth case?
So usually in Parkinson's, how do they present? What is the symptom that appears in the as a case?
Yeah, you mean in station 3?
Yeah, not
Yeah.
in station 3, but in station 5 or in station 2, if we have.
And station 5, it's come before Parkinson disease patient, but the patient will tell you that, doctor, I have wrist tremor, rather than this tremor or this shakiness of my hands become when I rest my hands or I don't move it. And also I feel that my movements become more slow. Okay, and will tell you sometimes the other and if the Parkinson disease come in the examination, so you should now confirm the diagnosis. As we know, this is spot diagnosis, so confirm the diagnosis first by asking the patient about wrist tremor, about slowness of the movements and difficulty of walking, and then you should rule out complication like constipation, as we know that patient with Parkinson disease has constipation, and also postural hypotension. Very important to ask him, do you feel dizzy when you stand from lying position to upright position? And you should rule out the Parkinson plus syndrome by asking about autonomic manifestation like impotence, like difficulty to control urine, and ask about dementia. Do you see image that the other cannot see it? Do you have any episodes of confusion or restless or difficulty of memory? Okay, and when you examine him, you should examine eye movements to rule out progressive supranuclear palsy by the patient have disturbance of upward gaze,
Right.
like this in station 4.
Right. Thank you.
But really, it's not common to, most likely you will see essential tremor rather than Parkinson disease in station 5. Why? For one reason. Because next year really can be appear in the exam. Because 8 minutes not enough to take history and examine patient with Parkinson disease. Really not enough. 8 minutes not enough.
That's because you have to rule out all other Parkinson plus syndromes.
Yeah,
So
you are right.
yeah.
But next year, suspect to see him. Next year, because 15 minutes, so Parkinson disease can appear next year more frequently.
And do we have, Dr. Hassan, to stop driving, or like, do we have any other restriction to this patient?
Very important. I think I don't know if we have a session for this course about Parkinson disease, but we discussed it before in the free session about Parkinson disease. We mentioned Parkinson disease, he should seek advice from DVLA. He should seek advice. Yani you should refer him to DVLA, because sometimes if the patient tremor or symptoms affect daily activities, so he should seek advice. But if the symptoms control it, so he can drive, no problem. Nobody will prevent him to drive if his symptoms controlled by medication. But if the patient symptoms, you examine him and you feel that these symptoms can affect driving, you should tell him that to seek advice from DVLA.
Sure.
Only the disease, should advise the patient to stop driving 100% if the patient has loss of vision or loss of consciousness. This is two disease. You should tell him, please stop driving, clearly stop driving, while to solve your problem. Okay? Other than this depends on your evaluation. If you feel that patient has severe tremor in your exam, so you should tell him, please, I advise to stop the. If the patient has ankylosing spondylitis, severe neck stiffness, he cannot move his neck from side to side, you should tell him that stop driving. So this depends on evaluation in these stations, but only loss of vision, loss of consciousness, you should stop driving. You must not stop, you must stop driving, but in sympathetic way. Fourth case will be for Dr. I think Abdullah. Dr. Abdullah, you are here? Or Dr. Hassan, I don't know. I will open.
Yes, I am here, Dr.
This case for you, Dr. Abdullah, I think.
Okay, yes, this is my case, the first one.
Yeah, very nice case. Also very nice case. Station 4. I will give you 4 minutes or 5 minutes because I should bring water. Okay, take your time. 5 minutes, doctor. You are a doctor?
Yes, I'm ready, Dr. Hassan.
Yeah, we can start, Dr. Abdullah.
Okay, hello.
Hello?
Yes, I'm Dr. Abdullah. senior house officer in the emergency department. Can I confirm that you are Mr. Salim, 30 years old?
Yes, doctor, I'm Salim.
Okay, we are here today to discuss regarding your health condition.
Yeah, doctor,
That
please,
is
please.
okay with
Yes, doctor.
you?
Yes, doctor, it's okay.
Okay. Are you relaxed or you want anybody to attend with us or it's okay?
No, it's okay, doctor. Thank you.
Okay. Can you tell me, please, Mr. Salim, how far you know regarding your condition?
Actually, doctor, I have been suffering cough, tiredness, night sweats since around 3 months. I lost a lot of weight over this period, and my body temperature is high most of the time over the last month. When I went to my GP, he did chest image for me and told me that can be infection and should go to the hospital. So I came here, doctor.
Okay, it is, you are right, Mr. Salim, and one of your blood investigation is ready now, and that report shows that you have a condition called tuberculosis.
Tuberculosis? I have tuberculosis, doctor?
Yeah.
Oh, I know that. It's serious disease, doctor.
Can you tell me how far you know regarding this tuberculosis?
Yeah, doctor, it's common disease. I read in the media and I see many times people with tuberculosis before. But
Yeah, you are right.
I know that it's serious disease, doctor, and usually it's very rare here in our area, doctor.
Yeah, but Mr. Salim, I have a good news for you also.
Yeah?
The good news that this condition is treatable.
Ah, it's a curable disease, doctor? Can be managed
Yeah,
completely?
it is curable disease. Yeah, it is one of the conditions that can be treated
Yeah.
if you
How
follow
can treat it, doctor?
if you follow the instruction. So this tuberculosis, Mr. Salim, do you want me to explain you more regarding
Yeah,
this?
please, doctor, please. Yes, I know it, but I should know everything about this.
Yeah, this tuberculosis actually it is a bug infection
Yeah.
which affect your lung, causing this cough and fever and sweating and weight loss, loss of appetite,
Yeah.
and the important issue in this disease is that can be spread from person to person.
Yeah.
So yeah, regarding treatment, Mr. Salim, we will start for treatment together for 2 months,
For
and
treatment?
then we will continue by treatment for another 4 months. So the total duration of treatment is 6 months.
Oh, I should take this medication 6 months, doctor?
Yeah, you need to take it.
It's very difficult, really, doctor.
Yeah, actually, according to the national, international, and evidence-based medicine,
Yeah.
that is the only confirm effective treatment for this illness,
Yeah, yeah.
and you need to continue this for 6 months, as I told you, for drugs together, for
So,
medication together for
when I should,
2 months,
yeah,
and then
when I should start this medication, doctor?
okay. So now you have another report in the culture. Yes, we are waiting the report to come.
Yes.
Also, will support the diagnosis further, so we can start. But
So no need to
now
start
we
now,
need to
doctor.
discuss with you regarding
So no
we
need to
need to
start now,
discuss with
doctor?
you regarding this illness.
Ah, doctor? يعني we should wait to this result of culture, and after that we can start medication. No need to start now.
Yeah, now we can start. Now we can start discussing regarding the condition, and we need to keep you in the hospital,
Yeah.
and we need to do another our basic investigation. Also waiting for that result
Yeah.
at the time that the report came, so we can start the
So,
treatment
doctor, what the
as
outlooks
soon
if
as the
I
report came.
what the outlooks of this disease if I take this medication?
Yeah, Mr. Salim. The outlook is that this medication you will start for 6 months. The important issue is that one of these medication will change your uh, water work color to orange color, and maybe your sweeting also will be changed
Yeah.
to orange color. And one of those medication, sometimes in limited number of patient, can cause also like tingling sensation or burning sensation to the lower limbs or upper limbs to the nerve. But actually, we are adding vitamins to protect this from happening.
Yeah.
And also, at the beginning, we need you to stay far away from your family and from community also, because as I told you, this disease can spread from person to person, so you can spread it to your family and you can spread it to the community too.
Yeah. So, doctor, I should not work now?
Yeah, you need to, at the beginning, you need to stop working until the disease is well controlled. At that point, so you can continue.
But really, doctor, I afraid to lose my job.
No problem regarding that, uh, Mr. Salim. We will.
Doctor, it's
Can you
difficult
tell
to
me
get job.
your job, please?
Nowadays it's very difficult the one to get job. So really, it's problem for me to lose my job.
Okay. Can you tell me what is your job, please?
I'm working receptionist in the hotel.
Receptionist is hot. Okay. So we can include our social worker, and we can include your occupational health
No, no, no,
doctor
doctor,
also.
please,
It's a
please,
part of
please.
our team.
I afraid, doctor, to know that I have this disease in my job, my supervisor, and really, doctor, no need to inform them. Because, doctor, if they know
Yeah,
that I have this disease, can also sometimes blame me and bully me. Really, doctor, no need, no need.
Mr. Salim, we appreciate your concern, but actually, as I told you, this is a communicable disease. That means can spread from somebody to
So,
another.
doctor, you will tell them that
And
you will t
actually,
you will tell
I'm
them, doctor,
sorry.
that I have this TB, tuberculosis. You will tell my worker mate that I have this disease.
Yeah, we need to stop you from work. Actually,
Yeah,
Mr.
doctor,
Salim,
no
I'm
problem.
sorry for that.
I can't take vacation now. No need to inform anybody. I can't take vacation. I will take vacation, doctor. No need to tell anybody.
Okay, so we will stop you from working, and at any point that we feel that you are unable to spread this disease from you to another person, so at that point you can go back to your work.
Yeah, okay. And
And regarding that,
yeah,
you can
when can I resume my work, doctor?
at least we have first 6 months. You
Yeah.
need to continue for 6 months, and then after that,
Oh
we
my
need
God,
to
6 months. I
reassess
should.
again. And if you are, or at any point that our treating team decides that you are free from this bug infection, you can resume your work.
So I cannot work for 6 months now. Oh my God.
Yeah, I'm sorry for
Oh,
that,
it's difficult disease. Really,
Mr.
difficult
Salim.
disease. Really.
I'm so sorry.
Okay, doctor. Thank you, doctor. I will try to take vacation or anything else.
And I want to know also, Mr. Salim, are you earning enough money?
Only from my job, doctor. This job.
Okay, is it enough?
I think will not be enough if I will take vacation for 6 months. I cannot gain any money.
Okay. So we will include our social worker also. He will help regarding that. Can you
Thank you.
tell me, please, Mr. Salim, what about your family issue? Are you married? Do you have a kid? What
No, I'm
about
not.
the home?
I'm not married, doctor. But I'm living with my girlfriend.
Okay, so I'm sorry to tell you that we need you to isolate yourself and to keep her away also,
Yeah.
because this can spread from you to any other one who is in close contact to you, because this can spread by coughing, by breathing also.
So okay,
So
doctor. I will
we need
I
you
will
to
tell her
keep
that I need to
water
stay
around
at
you.
home alone. Yes, no problem, doctor. I will tell her to go to her home, and I will stay alone in my home.
Yeah, but we need to keep you in hospital, and we need you to be in isolation also in our facility.
Yeah, yeah. I should stay in hospital.
Yeah, we need you to stay in hospital.
For
Yeah,
how
and
long? For
even
how long,
at
doctor? I should stay in
hospital.
hospital.
Yeah, just now we are waiting for this blood report to come out as soon as possible. This report is out. We will start our treatment
Yes.
until the area that our treating team sure that your disease activity is well controlled, so you can go back to your home even before this 6 months,
Okay, doctor. Okay.
even maybe 1 month, 2 months, according to the treating team decision at the point that your disease is controlled.
Yes, doctor. One
Any
minute,
other
doctor. Abdullah.
concern, Mr. Salim?
Really, doctor, no concerns because now you explain everything and I can understand all. But doctor,
So, thanks a lot.
from where, doctor, I get this infection?
Yeah, but this infection, can you tell me, please, do you contact anyone with
Really, doctor,
cough and fever?
really, doctor, I cannot remember if I contact anyone with these symptoms.
Okay, do you travel abroad?
Yes, doctor, I was in Tanzania 6 months before.
So, you know that Tanzania is a country that which there is tuberculosis activity there. So, it could be from traveling, it could be in contact in that hotel to inform that
Oh,
you are
maybe.
working there. It could be from any other source, but actually, I'm sure that you get it from another one, because this disease is spread from human to human. So, you have a contact to ill personnel who spread this illness to you.
Thank you, Dr. Abdullah. Thank you very much. What legal issue in this
Thanks a lot,
scenario?
Mr. Salim.
What are legal issue in
This
this
is
scenario?
a legal issue. So, communicable disease.
Yes, can be mentioned. Yes, you are right. But what usually whether for communicable disease? Notification. Okay?
Yeah, notifiable disease. Yeah.
Notifiable disease. So also confidentiality should be also put in your mind because this patient mentioned to you don't inform anybody. So this confidentiality should not disclose uh, unless the patient refuse to follow instructions related to the isolation. Okay? طيب.
Okay.
My first questions. For how long should the patient with active TB isolated?
I think 2 weeks to 1 month, I think.
Usually continue isolation until sputum smear are negative for 3 consecutive determinations, and these usually after approximately 2 to 4 weeks of treatment. So why you would to isolate this patient for 6 months? Why tell him to resume his working after 6 months? After 4 to 4 weeks, if the sputum smear are negative for 3 consecutive determination, so this patient can contact with the other, no problem that time. You can discharge him from hospital. Now we will not transmit this disease. So this is very important because this will use in your scenario. So how long I should isolate it? You can tell him this is for few weeks, 4 weeks, but before that we should do some tests for your flame many times, frequently, to be sure that this is free from this is bug, and after that, and you are safe to contact with other without to transmit the disease for the other. The other questions. The other questions here, I think. So for how long? Then this is scenario of communicable disease. The most important part in communicable disease, what?
To inform, I think,
So notification, we told notification, okay, notifiable disease.
notification, yeah.
So you should tell the patient, because you will inform that now infection control department. So you should tell him that this is usually notifiable disease. I mean, I will mention this disease for the others. I mentioned for confidentiality. And also the most important part, tracing. I told you I will tell my girlfriend only to stay at her home. No, you should tell him that you should examine your girlfriend. Why don't tell me that to examine our girlfriend, our housemate, our workmate? We should examine all. Is it right or no?
Yeah, you are right.
Yeah. So this is any communicable disease. Notification and tracing. We should trace the all people that the patient contacted, because maybe his girlfriend now has also TB. So, and this girlfriend, if we're not tracing her, so maybe that transmit the disease to other and other and other, and will go to the many people will affected. Also, workmate, housemate, close contact with the patient should be notified. Should be traced. What the type of isolation should be done for patient with active pulmonary TB?
It's negative pressure isolation.
Yeah. Can the visitor come and see him?
They can
So,
come, but with a precaution.
with
With
precautions.
masks like this.
Can child visit him? If we suppose, because this can be question in the exam. So can child, if they told you I have one kid's 2 years or 4 years and I want to see him, can they visit him?
I will try to explain to him that his child visiting is very risky to the child if he is insisting, so he can visit with precaution. But I will advise him not to.
Yes, usually we advise
To
to then don't visit him, but if he insists and insists and insists, tell him that I will arrange with my consultant and take the decision, or take I will discuss with my consultant and also with my infectious management team to see how can allowed for him to visit you. And give him answer. If he insists that for child, because usually not allowed for child to visit him. So if he insists in exam, no doctor, I will discharge, because there is other scenario that the patient, he will to discharge himself. And when you ask him why, he will tell you, because my children, I cannot see them, they cannot visit me. So in that reason, if he insists and argue you, tell him that be sure that I will discuss with my consultant and infectious control team that will arrange one way to try to see your children. But don't tell him that it's allowed. Don't mention it for him, okay? Try to escape. Thank you, Dr. Abdullah. Thank you very much. Really, this is important scenario. Very important scenario, especially for this year. I think this can be applied for open TB. This scenario apply for meningitis, meningococcal meningitis. This can be applied for COVID-19. Really, this can apply for all these cases. Also COVID-19, as we know now, COVID-19, it's notifiable disease. We should notify and we should trace the people who contact with the patient with COVID-19. It's right in this now, in this pandemic. We should tracing the people. Now we are here in hospital, tracing the people that contact. They ask the patient who was with you, with who you contact, and really they bring him and take sample from them. So this can be applied in this year on COVID-19 like this, in station 4. So very important issue. This is if you face case of open TB, of meningitis, of COVID-19, you should also doing all the steps, especially notification and tracing. Trace the case, the contact people. طيب. TB. What's TB? TB is lung infection caused by a specific type of bug transmitted by person when sneezing or cough. This is the definition, it's clear. Clinical features: cause cough, phlegm, cough up blood, high body temperature, night sweats or sweet, feeling unwell, weight loss, poor appetite. You may become breathless if the infection progresses and damage the lung. Complication. As we know, for any disease, mention, definition, clinical pictures, complication. Tell the patient if the disease left untreated, complication often develop, such as fluid collection between the lung and chest wall. This can make you very breathless. As we know, pleural effusion, it's common in patients with TB, and this is responsible sometimes for complication. And the other thing, as Dr. Abdullah told me, that TB infection, if not treated well, can spread from the lungs to cause infection in other parts of body. And depending on which part of the body is affected, various symptoms may be then occur. And this can affect bone, gut, tummy, kidney, bladder, brain, skin. You should mention important parts, especially brain, kidneys, bone for patient. And this can cause serious complication. As we know that meningitis, TB meningitis is very serious disease. Treatment, you should explain for them these points. That normal antibiotic don't kill TB germs or bugs. Normal antibiotic don't affect the TB. So you need to take combination of special antibiotics for several months. Not necessary here to mention the names because it's not mentioned in the scenario to explain detail. Only you can tell him that we should use combination of special antibiotics for several months. And you can tell him usually the standard treatment in the UK is usually for 6 months. First, it involves combination of 4 antibiotics that you take for 2 months, then followed by continuing with 2 medication for further 4 months. طبعا you should explain him this important point that TB bacteria in the body are more difficult to get rid of than the ordinary bacteria. Why? Because to convince patient to accept this medication for 6 months, so you should mention for them that it's difficult to get rid of than ordinary bacteria. And you should mention, if you don't take the full treatment, then the following problems often occur. What's the problem? You may remain infectious to other people, transmitted the disease to the other people, and you may not be cured. You may feel better at first, but some TB bacteria may stay in your body, and this can reactivate at later time and make you very ill. And tell him that if this infection is only partially treated, the bacteria can be resistant to antibiotic. So this is very important point. To convince patient to take medication, you should tell him the complication. That first of all, that the infection will still, and you will be transmitting this disease to the other. And also, you may not be cured. And also, this bacteria will be resistant if you take this medication for a short time and then stop. Yes, you will feel well. As we know that patient with meningitis, with tuberculosis, after 1 month will feel very well. But when you stop medication, the symptoms will return back, and this will make the disease more resistant to the treatment. So, you should mention for the patient the treatment duration 6 months, and you should take it regularly for 6 months. And why? Because if you stop this, if you feel well after 1 month or 2 months and stop this medication, so this will be make the bacteria more resistant to treatment and difficult to get rid from your body later on. Outlook: with the treatment, most people make a full recovery, as we know. But if left untreated, about half of people with active TB eventually develop serious complication and may die. You should mention death for him. Why? Because as we know, if the patient of TB not taking medication, so he really will die. Social history, very important here, especially if the patient has any history of travel. And alcohol, very important also. We know can alcohol here interact with the medication. Illicit drug. In this scenario, it's mentioned clearly, if you have time, you can discuss about HIV. But if you have no time, no need to discuss. If you feel that you have time to discuss about HIV, you can do. Isolation. Tell the patient, so the main parts of this scenario, explain the disease and then discuss the isolation. Isolation, tell him that the aim or the purpose from isolation, first of all, the benefit for you, because the patient with tuberculosis can easily catch other infection and this can worsen their condition. And the second, to protect the other people, because as I told you, this disease can be transmitted easily from one to the other. So, isolation for two purposes. First one, for your benefit, because patient with TB can easily catch other infection. Second purpose is to protect the other people, because this disease can be transmitted easily. The relative can visit you, but after washing their hands before and after visit, wearing gloves and gown, and specific mask, usually not allowed for children. But as we mentioned, if the patient insists, you can try to convince him by sharing your consultant and infectious control department. And you tell him that during the first few weeks of treatment, you will be advised, you will be advised to be in this isolated room, as we mentioned. Notification. Tell him that TB is notifiable disease in the UK. So this means I should notify Health Protection Agency or Infectious Control. Health Protection Agency or Infection Control Department. Why this I should do this? To prevent the infection to transmit it to the others and to identify the source of infection. Now, the patient will tell you, and I told you, do you will inform my workmate that I have TB? I will become angry later if you will disclose my confidentiality. No. This does not mean that I breach your confidentiality. Only we can tell the people that we need to investigate you, because when people contact with him, maybe has risk of disease can be transmitted by person to person. We will not mention your name unless you give us permission. So if the surrogate asks you, you will tell my workmate that I have TB? No. Tracing does not mean that I will inform them that you have the disease. You are the one that you have disease. Okay? This is very important point, and this is a question in the exam. So contact tracing. Also tracing, this is to identify the people who with close contact with the patient by investigation and the prophylactic treatment if needed. So you can tell them that we should trace the people that with close contact with you to do some tests for them, and maybe they need to give them medication also to prevent the disease to develop more. Because early treatment can prevent serious complication and transmission of the disease to the others. For his girlfriend, you should trace her, you should examine her. Don't tell him, yes, you can stay at home. No, I should tell her, you should inform her to come and to do test for hair and may need treatment. Concern. When I lost my job, say that he needs to contact occupational health department as soon as possible, but he should refrain from carrying out any direct contact until he has been established on a treatment for at least 2 weeks or sputum smear negative, as we mentioned for you now. So he can resume his work when he can also contact with the other people. When sputum smear is negative for 3 times, and usually this is achieved after 4 weeks. طيب, before I will ask you if you have any question, because I have another thing I should discuss with you. Anyone have a question, please, now?
The job sector, should I notify them also or don't breach the confidential here?
For what, doctor?
For his job sector?
Yeah, for his job, as I told you, that we should not breach his confidentiality, but we should trace the people with him.
Okay.
But if he asks you, how can tracing them without to mention it for him? No, I will not tell anybody that you are the one that you have the TP. You understand me?
Okay.
Yani you should stop your working, either to take vacation, either to do anything to inform your occupational health worker, because the patient maybe tell you, no, don't tell my occupational health worker, I will take vacation, I will not go work. But I should trace them. I should trace your workmate, and I will bring them and I will do, but I will not tell them that you are the one that the patient. For confidentiality. Okay?
Yeah.
So, Dr. Hassan, sorry for interruption. It is
Yes, doctor.
mentioned in the scenario that acid pass bacilli done and waiting for culture
Yeah,
report.
this is a very
So
important
the
question.
question,
Yes.
that question. So we will start. You will start treatment
Yeah.
now, or what? Really, I was confused at that point. So I don't know.
Very important point. How long the culture need to be to get the result? Sometimes we need 1 month, sometimes, or 2 months. So when you suspect that this patient has TB and the sputum showed that acid fast bacilli is positive, so you should start. You should not wait the culture. Sometimes we can do PCR. Yes, PCR.
Up to 6 weeks the culture will take, so to
Yeah.
start.
Yes, you should start. You should start directly. And even PCR, we know that PCR sometimes need 3 days to 1 week. You should start while the patient have the symptoms consistent with tuberculosis. You should not wait. Okay, but now it depends on sputum acid and alcohol bacilli, this fast bacilli. So here, when he tell you that when you start doctor treatment, you should tell him we should start as soon as possible, because as we tell you, because this serious disease, if kept without a treatment, so this can cause serious complication for you. So here, maybe as soon as possible we can start. And we know, all of us know that any patient with TB, sometimes we can start treatment on clinical picture if we have high suspicion that this is TB. Is it right? Yes.
Yeah.
Any question? So you can start as soon as possible. We'll keep you in hospital, in isolation room, and we'll start as soon as possible, and we'll wait the results of the culture.
Sorry, Dr. Hassan, is the only open TB, COVID-19 and meningitis notifiable disease, or any other disease like HIV?
Yes, HIV. It's not a viral disease. Also,
Yeah.
yes, you are right.
Yeah. Okay, thank you.
But we have this is cases about HIV.
Okay.
In this course.
Thank you.
Other question, please. So, we have other scenario appear in the exam about TB, but not like that. The scenario come that patient diagnosed as TB and given treatment, discharged from hospital after 4 weeks. He went home, but this patient not collect more medication, so not taking now medication, and the symptoms return back for him. This is more difficult scenario. How can approach this patient? First of all, you should ask patient why is not take his treatment. You can ask him about side effect. Maybe this patient not take this medication because it's side effects. So you can manage his concern. Maybe this patient because he forget. He told you that, oh, doctor, many medication, I cannot take it. I forget to take it. Maybe the patient, maybe, yeah, 1 minute. Maybe the patient, he cannot get the tablets from pharmacy or from his GP. So you should know first why this patient not compliant to treatment. This is the first issue. Then ask him the risk of non-compliance to treatment. Tell him that you may remain infectious to the other people. You may not be cured. If the original infection is only partly treated, the bacteria can become resistant to antibiotics and the TB become more difficult to treat. So this is the issue. If the patient not compliant to treatment, this can be transmitted the disease to the others, can be not cured, and this will cause life-threatening complication, and the original infection is only partly treated, so this is can become resistant to antibiotic. And then you can explain the risk of complication, that this disease can spread to the other parts of body, can affect the brain, can affect the kidney, the bone, and can so also cause life-threatening complication and also can cause death. Then you can explain him about what called directly observed treatment. For patient non-compliance to treatment, as we know that there is a scheme called directly observed treatment. What this given to the patient has difficulty with taking the medication at the current time. And what the benefit from this? It's only 3 times a week. Also, this will be altered according to how he's doing. He does not need to remember to go to his GP and pharmacist to get the prescription treatment. So, if the patient non-compliant to treatment, you should discuss with them directly observed treatment. Directly observed treatment in tuberculosis treatment, where ingestions of every drug is witnessed, okay, is recommended in non-compliance patient, particularly the homeless people, alcoholic, drug abusers, and the patient seriously mental illness, patient with multiple drug resistance, and those with history of non-compliance. So, other scenario, if the patient non-compliant to treatment, how can dealing with him with this drug, as we mentioned, directly observed treatment. Any question about this scenario?
So in this case, we mentioned there is a notifiable disease. So we notify it to the health concerned health department or who?
Really, I read two things. We can tell health protection agency. Health protection agency. I think in UK, this is one department that usually responsible for disease or infectious control disease. But as I told you, because we are working outside, so it's not necessary to know in details. Because as we know now, in most countries there's departments called infectious control department. Okay, but in UK, I read one time in the also communication skills in for UK tutors that he mentioned health protection agency.
Okay. Okay, thank you, sir.
Thank you. Other question? Last case, Dr. Saima, I think.
Yes, sir.
Dr. Saima, what is the weather time in your area now?
It's 8:45. I'm in London.
Ah, very nice. Because always I give you the case at the end, so I afraid that to be in Far East. Okay, very
No.
nice. So, Dr. Simon, what's the department in the UK usually? Protection Agency Department or what? What's the
Actually,
name?
I'm really new here. I'm from Bangladesh.
Yeah,
Actually,
yeah, yeah.
my husband is working here,
Yeah,
and
but I think its name, this is one, Health Protection Agency, it's called.
okay, okay. I will ask someone.
But if you mention infectious control, nobody will blame you. Why? Because this is the, usually it's, in most countries, it's called infectious control department.
Okay, yeah.
This is your case, doctor? You have 2 minutes.
Okay.
We can start, Dr. Simon, please.
Yes. Okay. Hello, I am Dr. Saima, one of the senior house officer in this medical outpatient department. Are you Mr. Lauren, 40 years old?
Yes, Doctor, I am Lawrence.
Lawrence. Okay, nice to meet you, sir. Okay. Can you please tell me what is bothering you?
Really, doctor, I have this rash affect my legs. Start about 2 weeks before.
In your legs?
Yeah.
Okay. And was it sudden onset or gradual?
Really, doctor, it starts suddenly.
Start suddenly. And for how long you are suffering actually?
2 weeks, doctor. Start
Two
about 2 weeks
weeks.
before only.
Okay. Is this the first time in your life?
Yeah, this first time.
Okay. Is it progressing day by day or getting worse day by
Yeah,
day?
doctor, it was first it was red on the first week and
Mhm.
then become like this.
Okay. May I show you rash?
Yeah, please, doctor. This one.
Okay. Okay. Become okay. Do you feel any pain on this area?
Yeah, doctor, it's very painful.
Okay. And any itching in that area?
Not itching, doctor, but really it's painful.
Not itching. Any discharge from this
No,
area?
no, doctor.
Okay. 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 So, did you notice anything worsen your condition? Like any creams or emollients? Did you know
No, no.
used it? Okay.
I didn't use it, doctor.
Okay. And anything relieves your condition? Are you taking any medications for this?
No, I'm not taking the any medication.
Okay. Um, uh, so it's painful. So may I ask, do you have any shortness of breath?
Yes, doctor, I have.
Shortness of breath. For how long
Yeah.
you are suffering from this?
Since 3 months, doctor.
3 months. And your shortness of breath is related to your exertion or all the
Yeah,
time?
yeah, yeah, doctor. It increase when I'm walking fast or climbing stairs. Really, I cannot tolerate now to climb stairs.
Oh, okay. I'm very sorry to hear that. And do you cough? Do you have cough?
Yeah, yes, doctor, I have cough also since 3 months.
And coughing out of blood?
No, no blood.
No. Okay. So, is it your cough dry or sometimes
Yeah,
wet?
doctor, it's dry, dry, yes,
Dry
really.
cough. Okay. So, may I know, do you have any chest pain associated with?
No chest pain, doctor.
No, any racing of your heart?
No racing of my heart.
Okay. Any joint condition you are diagnosed with before or you have?
Nothing before, but really also, doctor, since 6 weeks also I have joints pain affect my both knees and ankles and wrists. Really, doctor, it's difficult.
For 6 weeks, you are
Six
having
weeks,
joint pain?
only 6 weeks, 6 weeks.
Okay. And do you have any morning jamming with the joints? Morning stiffness?
No, no, doctor.
It's all the time you're suffering
Most
from
time,
joint pain?
most time, yes, most time.
Okay. So do you have any back pain also?
Back pain, no back pain.
Okay. So any other body parts area rash? Any other rash?
No, only this rash.
Only this rash. Okay. So do you have any other condition like tummy pain?
Yes, really, doctor, I have also tummy pain.
Okay. And which part of your tummy?
Upper part, like burning sensation I'm feeling.
Burning sensation. Okay. May I know your medication chart? Any medication you are using now?
Only sometimes I'm using, now only this 2 weeks, I'm using ibuprofen for this pain in my legs.
Only ibuprofen. Okay. Any over-the-counter medication?
No, no,
Okay. And do you have any high blood pressure?
no,
Any high blood sugar?
no,
Any past medical condition that I should know?
no, doctor, nothing.
Any family members suffering the same condition?
No, doctor, nothing, nobody.
No. Okay. And I want to examine you as well as talk to you. Is that
Yeah,
okay?
please, please, doctor.
Okay.
What
So
will
I
examine?
so I want to check the rash first with the gloves, and is it tender or not, and the
Yes,
temperature also
yes,
raised or not,
yes,
and rash is blanchable or not,
yes, very nice.
uh, and uh, and the joint regarding the joint, I want to do the check the active passive movements, any tenderness present or not.
Yes, very nice,
A patient has shortness of breath, so I am to check the lungs also, any crepes
very
um,
nice,
present or not,
very nice.
and
It's normal in this patient, normal in this patient.
all are normal.
What will examine also?
So I want to know what about your back passage work? Any
Hard,
change
I
like
have hard,
loose
yes, doctor, hard motion. I have hard motion.
hard motion for how long?
For also about 3 months.
3 months. Your hard motion and your water work
Yes, doctor, I pass urine more frequent and more amount.
increasing more for the
Yeah,
same duration.
yeah, about 3 months also.
What about your mood?
Really, doctor, I feel that low mood.
Low mood for the same duration.
Yeah,
Okay. So did you notice regarding your motion? Did you notice any blood?
no, no blood motion.
Okay. What is the difference the previous motion and now? It was
Yes, it
all
was
right.
okay, it was normal, doctor, but since this period, I feel that high motion. I open my bowel 3 times only per week, and I strain to open my bowel.
Do you have any weather preference?
No,
No weather preference. Okay. Mm, may I know any family history of note, like cancer or
no, doctor,
um,
no, nobody in my family
mm, no?
has disease.
So, okay. Do you smoke, sir?
Yes, only 10 cigarettes since 10 years, doctor.
Since 10 years. And do you drink alcohol?
10 units per week, doctor.
10 minutes per week. And what do you do for your living?
I'm teacher, doctor.
Or is it affecting your daily life?
One minute. Yes, doctor. Really, it's affect especially this shortness of breath and dry cough.
So what's your concern, sir?
What's the cause of these symptoms, doctor? I have many symptoms.
Okay. After talking to you and examining you, I have some possibilities in my mind. You are suffering from a condition which is called sarcoidosis, I think, but don't bother with the name. Before that,
Yeah,
I will do some blood test and imaging for
yeah,
your joints, and
yeah,
also I may need take a sniff from the rash to confirm my diagnosis also. And I
yeah.
will form a multidisciplinary team for you, which will include the joint doctor and gut doctor and the specialist nurse, a mood doctor and a skin specialist also for you. And
Great, Doctor Simon, really great.
I want to give some advice for you regarding smoking and alcohol.
Yeah,
If
this
you
is
feel,
this is really always manage it at time. Yeah,
okay,
first I tell you I am smoking 10 cigarettes. Please, I would you would stop smoking because smoking can affect all parts of the body, especially that you are now have lung disease. So really, directly, to don't forget because you forget now. Time off.
okay,
Okay.
okay.
Yes. So first of all, what's this skin lesion? Describe me this lesion.
Okay. Skin lesion is erythema nodosum.
Yeah. Describe me.
Okay. The rash is maculopapular rash. Uh, what should describe?
Because really, this is an exam at the core. The
Okay.
examiner will tell you, let me what this is rash. Describe it. So, as we know that usually erythema nodosum is nodules,
Yeah.
nodules. So you can now tell me that this is poorly defined red. طبعا red it's color red. Tender
Tender.
nodular lesions of varying size. You see, its size is different from one to other. So clearly, this poorly defined red tender nodular lesions. Nodular, very important
Okay.
because it's nodules. Erythema nodosum, from its name, erythema nodosum. So it's red and
Nodular lesion. Yeah.
nodule. Erythema, red, and nodular lesions of varying size. This only. This is what you should mention for the examiner because can ask you what the so erythema nodosum. What the underlying cause for this lesion in this patient?
Um,
Yes, you are right. You told me
yeah. Sarcoidosis.
sarcoidosis. What the evidence of sarcoidosis in this patient?
The patient has the features of hypercalcemia and also shortness of breath.
And
Uh,
erythema nodosum.
and
So
the
the patient
erythema,
has respiratory symptoms of
respiratory
shortness of
symptom.
breath and dry cough, have erythema nodosum, have symptoms of hypercalcemia. So what the causes? Sarcoidosis.
Sarcoidosis.
So what investigation you will do for him?
I will do the full blood count
Yeah.
with ESR-CRP and check the creatinine, serum creatinines, and also the renal function test also, and 24-hour calcium,
Yeah.
calcium and ACE level also. Serum is
Corrected calcium and hypercalciuria and urine calcium. صح, you are right. Very nice. Corrected calcium plus serum calcium and also urine calcium because it's also increase in the patient with sarcoidosis.
yeah,
What else, doctor?
and check stress ray and HRCT also do lung function test.
HRCT. Very nice. You should mention HRCT. What else?
Lung function test on and for the
Pulmonary function. Very nice. Very nice. Pulmonary function test.
ECG to hyper features of hypercalcemia in rhythm abnormalities.
Do you forget one blood test?
SC inhibitor, SC level, sorry,
Angiotensin converting enzyme level. Very nice, doctor.
level. Yeah.
And also alkaline phosphatase can be elevated in this patient.
Okay.
You mentioned for me also biopsy. Why not mention now? You mentioned for the patient.
Yeah, skin biopsy also.
Yeah, biopsy. Okay. What are histological findings?
staging,
Histological.
histological granulomatous.
What granuloma? What the type? This is a question, huh? This is exam question, yeah, because this is
Yeah,
common. This is common question, and this is all of no. You know it. I know it. I'm sure. Non-cassating
non-cassating granuloma. Yeah.
granuloma. This is it's known from medical. يعني, for all you know this. Okay. What are stages of sarcoidosis on CT?
So stage 0 is the normal findings.
Yeah.
Stage 1, the bilateral hilar lymphadenopathy.
Yeah.
2, bilateral hilar lymphadenopathy plus pulmonary infiltrate.
Very nice.
Stage 3 was the infiltration without a hilar lymph node.
Nice.
And
And
stage
stage
4 was only the
fibrosis.
fibrosis. Yeah.
Very nice. What treatment you should give? This last question. Oh, no, we have other question. Treatment.
Steroids is the first line treatment. If the fibrosis present, I will start the
Yeah. So steroids. There's indication for steroids. Not all patients will take steroids.
Mhm.
Okay, like if the patient has extrapulmonary sarcoidosis involving
Brain.
critical organs, brain, heart, liver, kidneys. So these
Yeah.
patients needs corticosteroids.
Corticosteroids and
Or
other
if the patient has,
antimetabolites.
or if the patient has significant respiratory symptoms.
Okay.
But other than, we can use non-steroidal anti-inflammatory indicated for the treatment of rheumatological manifestations and
Methotrexate, azathioprine, we can
yeah,
use.
also methotrexate and azathioprine also can be used as alternative to prednisolone. Also, we have the other disease like chloroquine and hydroxychloroquine. This used for cutaneous lesions.
Mhm.
Okay.
Yeah.
طيب, last questions. So also infliximab can be used
Infliximab can be
also
used.
for refractory sarcoidosis. Okay. You know anything about syndrome called Lofgren?
Lofgren syndrome. Yeah.
Is it
Yeah. Yeah.
generalized lymphadenopathy, erythropathy?
Erythema
Yes,
Yeah, yes.
erythema nodosum.
Yeah. This is case in station 2. This came before in station 2. That this is acute sarcoidosis. Acute sarcoidosis. The patient present with fever, arthritis, and lymphoadenopathy, erythema nodosum, and uveitis.
Uveitis also.
And usually has good prognosis with complete resolutions within the month. So how can this case came? Patient has fever, erythema nodosum, respiratory symptoms like cough and shortness of breath, and uveitis. Okay, for examination, patient you suspect now, first of all, start with legs to see the rash, as you mentioned for me, inspect the rash, take the permission from patient, I will touch this to see if nodules, and tell the patient, if you feel pain, please tell me directly, I will stop. Usually the patient will tolerate because he give you permission. Okay, so examine the rash by also see if the temperature, if also blanchable or no, and then you finish the rash now, the patient has respiratory symptoms, so go to lung. Examine for lungs for fibrosis if he has any evidence of fibrosis. Then, because now you suspect that this sarcoidosis, you should go to the eyes to see if there's any signs of uveitis. So this is very important. And really, Doctora, you manage your time very well. And you have time. You have time to explain me also at the end what the diagnosis. So don't forget to examine the eyes because now we are examining patient. We suspect that sarcoidosis and the joints, as you mentioned for me. You forget only to examine the eyes. Eyes look for redness and visual acuity only. No need to examine more. Only tell the patient to close one eye. You can see well, and other eye you can see well. Why? Because as we know, uveitis can affect also the visual acuity, not only redness and visual acuity.
Is it, doctor, if it is acute, is it associated with polyuria or no?
No signs of
Okay.
hypercalcemia.
Okay.
No symptoms of hypercalcemia.
Okay.
Only fever, arthritis, erythema nodosum, uveitis, and hilar lymphoadenopathy, so the patient can have shortness of breath. So, first of all, as we mentioned, Dr. Saima, first step, the patient tell you, I have skin rash, please show me the rash. This is can give you very close, can خلاص you know now the diagnosis. يعني if you see this rash, from beginning you know that diagnosis. I need from you to know for each rash in your mind, put map in your mind and really repeat it before the exam, because in the exam you don't know what's the rash from outside, you don't know. So put in your mind differential diagnosis of each rash. And before the exam, what I did before my exam, I read in the paper erythema nodosum, I write differential diagnosis and I read it many times. I read bioderma gangrenosum. I wrote differential diagnosis. Why? Because when outside you cannot prepare. You cannot prepare first skin rash. Really, you cannot. What you write in your paper? You cannot write anything because you don't know which rash this patient has. So try to learn yourself or training yourself about each rash. So for erythema nodosum, I need you to know only some differential diagnosis common in exam. First of all, sarcoidosis. This is the most common cause in exam. Sarcoidosis as cause of erythema nodosum. Okay, so you should ask about full respiratory symptoms and tuberculosis. So sarcoidosis, tuberculosis. So respiratory symptoms can help in both, but usually in tuberculosis the patient has fever and travel history can give clue. 2, and this is what you forget to ask me, inflammatory bowel disease. So you should ask about only 2 questions: change in bowel habits, bloody motion. So you should target yourself. You ask me later on as symptoms of hypercalcemia, but you don't ask me directly about this. So you should put in your mind inflammatory bowel disease. So you should put your mind change in bowel habits, bloody motion. 3, myeloproliferative disorders. So you should ask about lymphoadenopathy. You have mumps or lumps in your body, and this can help you for TB also. Medication, drug, oral contraceptive pill, and sulfa. So either sulfonamide or sulfonylurea. Their other cause, the last cause, streptococcal throat infection. And so you can ask patient, do you have sore throat or high body temperature before to develop this one? So streptococcal. And as we know, erythema nodosum, anything can cause erythema nodosum. Anything can cause erythema nodosum. But usually this is the disease come most likely and in exam. So tuberculosis and sarcoidosis as lung disease, inflammatory bowel disease, myeloproliferative disorder, and streptococcal throat infection and medication. If you know all this, and there are other causes, but usually it's rare in real life and also not appear before in the exam. What appear before in the exam? Sarcoidosis appear, inflammatory bowel disease appear many times. Okay? Usually in exam, usually the examination will be normal of the lung. Usually pulmonary finding on the physical examination, usually normal.
So just to add, Behçet's is also a cause.
What is, doctor?
Behçet's disease.
Behçet disease, you are right. It's mentioned in Behçet disease, but not appear before in exam. It's mentioned in Behçet disease. Yes, you are right.
Okay.
It's mentioned Behçet disease can cause it, but really I don't put here because I put that will appear in the exam and the commons, because streptococcal also throat infection as common disease in real life. So for symptoms of sarcoidosis, what are symptoms of sarcoidosis? Can be asymptomatic, can be cause fever, anorexia, pulmonary complaint like cough, chest pain, shortness of breath, exertional, skin lesion like erythema nodosum, eye symptoms either anterior or posterior ovitis, heart failure from cardiopathy, and this is rare. And also, as we know, cranial nerve palsy, but don't forget hypercalcemia and hypercalciuria. Now we finish this case. I will, because no time in this course to discuss all cases, so I will only give you about this. What this lesion, doctor? Also in the leg.
So pyoderma gangrenosum.
Very, very nice. Pyoderma gangrenosum,
Pyoderma.
and this is also common in the exam. So only I need from you to know that necrotic ulcer, usually as you see the ulcer with rugged violaceous border. You see the border is rugged. You see rugged and
Yes, sir.
violaceous. Okay? And the surrounding skin usually indurated and erythematous. You see the surrounding skin will be indurated, atrophied. Okay? And usually this is present over the lateral aspects of the lower leg. Differential diagnosis like erythema nodosum, inflammatory bowel disease, sarcoidosis. Okay? Inflammatory bowel disease, sarcoidosis, myeloproliferative disorders, but here we can increase rheumatological disease like rheumatoid arthritis, ankylosing spondylitis, psoriatic. Okay?
Okay.
طبعا Wegener granulomatosis is also important in this one, and thyroid disease. So, but put in your mind for the causes of both together. Inflammatory bowel disease, sarcoidosis, both can cause. Myeloproliferative disorders, both can cause. Here you can increase only rheumatological disease, rheumatoid arthritis and ankylosing spondylitis, and you can increase also thyroid disease. Okay, what this lesion? I will show you the last one also because it's looks in the legs, this one. What this one?
Necrobiosis.
Yeah, complete.
Yeah.
Necrobiosis
Right.
Necrobiosis, the diabetic.
lipoidica.
Yeah,
diabetic.
this is also common in exam because it's common in the real life. Okay, this is how it's how this approach of diabetic approach. How? So diabetic approach, we have one case, I think next session, about how can approach patient with diabetes mellitus. We find one symptoms and how can approach patient with diabetes mellitus. Okay, so don't forget this rash. It's clear that as you see, well circumscribed ovale plaques on the interior surface of the lower legs. Look shiny surface. You see shiny surface with waxy yellow atrophic centers, as you see. And we have some, I think, telangiectasia. It's clear here. You see here some telangiectasia. You see here like this. You see, small. You see, but it's clear. Also multiple. You see multiple. You see, and here the brown, the margins will be brown. Okay, this usually the lesions came in the exam like this, but we have no time to discuss all, so I choose the most difficult one, erythema nodosum, and pyoderma gangrenosum, also most very important, also can become. I finish today. If any question before to close.
Dr. Hassan, one question about the sarcoid. If the patient asks, is this disease, so we have to say, is it only chronic inflammatory disease? How to describe it? Because in case it came in station 4, I'm thinking, and is it self-limiting? Is it curable 100% like this?
Incurable? Not
like,
incurable.
is it curable? So
Not,
the patient asks as a
not,
concern. And how to
yeah.
describe sarcoidosis in layman language in station 4?
Sarcoidosis also, it's thought that this is autoimmune disease also, as we know. That also can tell him the same thing, that this is the vein system that usually responsible to attack the body against the bug, also is affected and start misguided and start to affect your body. And this is caused, affect multiple parts of the body, but most likely affect the lungs and cause scarring in the lungs. Scarring. This scarring means fibrosis. Okay? Affect the lungs, and this can cause shortness of breath, dry cough, and sometimes can affect the brain. So it can cause all parts.
So it's I will not say soreness, or I will say it's a chronic type of infection, or what?
Not infection. Sarcoidosis, not infection.
Yeah, an inflammation. So is it better to describe it as soreness?
Scarring.
Scarring. Okay.
Scarring mean fibrosis or mean inflammation. Scarring mean inflammation also. And usually you can use inflammation, not wrong to use inflammation. And it's usually as we know, it's controllable disease. Tell him that sometimes we no need to give the treatment like immunosuppressant treatment. As we mentioned now, this treatment only kept for the patient with severe disease, but the patient with the mild symptoms only that affect the skin, no need to give treatment.
So it's only lung and skin, no need to give chronic treatment for it, self-limiting.
But for lungs, as I mentioned, if the patient has significant respiratory like fibrosis, we need.
Okay, sure.
But if the patient only have a hilar lymphoadenopathy and no more symptoms, only dry cough, mild or like mild shortness of breath, yes, no need to give critical medication.
Okay, thank you, Dr. Hassan.
Thank you, doctor. Other question, please? But we know that sometimes we need lung transplantation if the patient has pulmonary fibrosis, advanced pulmonary fibrosis. Maybe you need lung transplantation. So it's serious disease, not easy disease. But usually, most of patients have mild to moderate symptoms, not necessary to develop advanced disease. Any question, please? Thank you for all. See you Friday, inshallah.
Thank you, sir.
Thank you, Dr. Hassan.
Thank you so
Bye,
much, Dr.
goodbye.
Hassan.
Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh.